So we're going to finish up what David did not get to finish on Monday, and then we'll continue into what we're supposed to do tonight. Motzei Shabbos, we're definitely going to have class. I know some people may not be able to make it, so you're going to have to listen to the tape version. But 9 o'clock, Motzei Shabbos, I need an hour or two to catch up because we're behind now because he didn't finish everything he needed to finish. And plus the 2 lectures I'm supposed to do tonight are fairly lengthy, and I don't think anybody will be paying attention if I keep on going and on going. So Motzei Shabbos, we're definitely going to have class 9 o'clock. And like I said, if you have other plans, you can't make it, I understand, but it'll be taped and you'll have to watch it that way. Okay. I caught up with everything that was supposed to be up on Dropbox and on YouTube. So all the videos are up there. And I think that's basically it. So let me get going with this so we don't fall any further behind. Okay. So he said that he finished off around slide 66, but I'm going to go back to the beginning of that section that he was doing. Okay, just get these last 2 people in. Okay.
Hello, Mr. Frank. How you doing tonight?
Good, good. Okay, so like I said, we're a little behind. So I'm going to try to get through as much as I can of the lecture we didn't finish the other night, Monday night, and also the stuff I'm supposed to do tonight, but I don't think I'm going to get everything done. And Saturday night, 9 o'clock, I'm going to finish it. If you can't attend, I understand that you may have plans and stuff like that, but please make sure you watch it on, YouTube or Dropbox, whatever you prefer. And that's it. Okay, so let's talk about, what we were talking about. So David was talking to you about patient assessment, okay? And we know, we spoke the other night, that patient assessment is basically how we're playing detective, okay, to figure out what we need to do for the patient, to figure out what's wrong with the patient. So we could be the best at all the different skills, giving injections, whatever we need to do, splinting, oxygen, but if we can't figure out that we know, that we have to do it on a patient, then it's all, useless. So patient assessment is, the foundation of everything we do. We have to be able to figure out what's going wrong with the patient, but we also have to keep track of that. We don't want to stay in the house an excessive amount of time, right? So that a lot of times we may start the assessment, but if it's a seriously ill or injured patient, that we should continue it in the ambulance or out to the hospital, right? We shouldn't waste time on the scene. If you're on the scene more than 5 to 10 minutes with a patient that is, accessible, where you can get to them and move them to the ambulance, you've probably done something wrong. You should really be in the ambulance minimum of within 10 minutes of arriving at the scene of a patient. Okay, so we said the purpose of the primary assessment, right, not the secondary, the primary assessment, and it's always going to be a test question, is to detect seriously life-threatening injuries and treat them in the order that you find them. So just remember that on the exam, that they're going to really stress the purpose of the primary is that you go in your A, B, C, D, E format. You check airway first. If there's a problem with airway, you fix it before you move on to breathing, and so on, right? So you may check airway, airway's fine. You go into breathing, breathing's fine. You go into circulation, and you find that he has a severe bleed, okay? And that's where you're going to be working until you can control that hemorrhage, that bleeding, okay? So when we're doing a assessment of a trauma patient, okay, it means that we've gotten our secondary assessment. It means we've gotten out of our primary. It means that they have no life-threatening injuries that we were not able to fix in the primary. Okay, and now we're checking them over. This is usually going to be done en route to the hospital, right? Your primary assessment is the stuff to save the patient. Not every patient has anything they need to be saved, right? I mean, if it's a minor injury, then you have nothing to do. But most of the times, if the ambulance is available, you responded with the ambulance, you're going to be doing your secondary assessment en route to the hospital, okay? So obviously the injuries can range from, a minor, tiny little cut to something life-threatening. But again, most of the time, secondary en route to the hospital, okay? So we're going to talk about what areas can cause life-threatening injuries, right? We know the belly with the spleen, Okay, the liver, they both bleed a lot. We know the chest has the lungs, the heart, right? So the head has the brain. So, pretty much everything but the extremities usually has life-threatening injuries. But again, you could have a severe cut on an extremity on an arm or leg that cuts an artery, and that could also be considered life-threatening. Mental status, we said, is always a good way, right? We saw a test question. What's the best way to get idea what's going on with a patient? Mental status, right? If they're awake and talking to you, they probably do not have a super life-threatening problem at that point, right? It's when the patients have an altered mental status or starting to become unconscious that we worry a little bit about them. Okay. So when we're going through our primary and our secondary, right, we're going to relook at the patient's airway status. Remember the term patent, P-A-T-E-N-T, is how we say that an airway is in good shape, right? So we always want to make sure that the airway is patent. We're going to take a set of vital signs at some point. We're going to look at mechanism of injury, which is how did the patient get hurt? So mechanism of injury is how did they fall off a ladder? Were they in a car accident? How did they get hurt? Now, sometimes mechanism of injury could treat you, right? Somebody falls off the ladder. Okay, so we think the mechanism is the fall, but we always have to think to ask them, did you get dizzy and fall off the ladder? Okay, or did you just lose your footing and fall off the ladder? Because if they tell us they got dizzy and fell off the ladder, there may be a medical problem leading to them to get dizzy. So they may be both a medical and a trauma patient, right? We want to know, obviously, older patients, okay, usually will not do as well with trauma as younger patients. And a lot of times very small patients, very young pediatric patients also have special things that we have to think about. As far as pre-existing conditions go, they're talking about, do they have any medical problems prior to their injury that's going to make it harder? So the other night we talked about people on blood thinners, right, are always a problem. We talked about people on blood pressure medications could be a problem because blood pressure medications are designed to keep blood pressure low. And if they're bleeding, right, their blood pressure is going to be low from the bleeding. So the things that the body would do to try to raise the blood pressure, the vasoconstriction, the increasing the heart rate, trying to compensate, will not be able to be accomplished because they have medicine on board that is designed to keep their blood pressure low. Okay, so just some things. And again, trauma patient hit by a car, you're not going to know what medications they're on. So sometimes, you have no way of knowing in the field. Okay, so the first patient we're going to talk about is a patient who has a minor injury, right? So it says, so let me just admit everybody. It says patient with a minor injury, low priority. In other words, they don't have any obvious life-threatening injuries. Okay, so what happens there is that we're not worried about them overall. Okay, we're worried about them more or less where are they complaining about their injury. Now, obviously, if they're a low priority patient, a minor injury, they're going to be conscious. They're going to be able to talk to you. So as the patient fell, broke their leg, fell, broke their arm, there's no major injury. Okay, but you always have to have in the back of your mind that just because, the obvious injury is their broken leg, that there could be other things going on. So they call it tunnel vision, where you just look at one thing. So let's say they had a bad fracture, the bone sticking through the skin, right? You're going to tunnel in on that injury and you may not look at them overall and get a good idea of could there possibly be something else going on with that patient. Okay, so when we have a low priority patient, we basically do what they call a focused exam, that we focus on what they're complaining about. So their broken leg, okay? And again, MOI or mechanism of injury is how they broke it. Their chief complaint is the thing that's bothering them the most, okay? So a patient can have more than one, complaint, but the chief complaint is, why did you call the ambulance? What is the main problem I'm here for? Not to say you don't want to know the other problems, but the chief complaint is the main thing that a patient, complains about, okay? History of present illness, okay, is, was there some medical problem, okay? Was what led up to the injury? It could be they just were clumsy, they fell, they were tripping, it could be no medical problem, but was there something that could have, illness-wise, right? Injury is trauma, illness is medical, that could have led to the problem, okay? So again, the chief complaint is what the patient tells you, and when you document it, you document it in their words. So you say patient states, and in quotation marks, my leg hurts. I think I broke my leg, whatever it's going to be, okay? So again, history of present illness, what happened to get them hurt, right? So, what was either the mechanism of injury or the medical problem that led them to have a trauma event and stuff like that. Again, when we're doing that focused exam in that minor injured patient, we assess the area where the injury and complaint is, right? We're not doing a global overlook of the whole body. We're kind of focusing on their broken leg and stuff like that. And you could always say to them, okay, besides your leg, is there anything else, that's bothering you? Did you, when you fell, did you hit your head? Did you have your hand out to try to slow yourself down? Does your hand hurt? So you could always look at other things. Now, when we do a physical exam, right? So physical exam means physical means touching, right? Like when you go to the doctor, they do a checkup on you. A physical exam means that you're examining the patient. So there's three basic techniques that we use. Observation is looking, palpation is touching, and you know already that auscultation is listening, right? So observation with your eyes, palpation with your hands, and auscultation with your ears, probably through your stethoscope. So when we're looking at them, symmetry, when it says abnormalities, that means it's not normal. Abnormalities and symmetry, right? So you look at not one leg, you look at both legs and see if there's a difference in the way the legs look, right? So when you're looking at a part of the body, you compare it typically to the opposite side of the body. Now, obviously, certain things don't have an opposite, right? You only have one head, but maybe one side of the head to the other. So you're always looking, does it look exactly the same? And when we look at the chest, remember, when you breathe, both your lungs inflate simultaneously, equally, right? So if the chest is only one side going up versus the other, you would assume if the patient's inhaling, the side that doesn't go up has some type of problem. It could be a rib fracture, it could be a lung problem, but the chest should rise and fall, right? Symmetrically. So symmetrically means equally at the same time and at the same amount, okay? When we're looking, we're also looking at the color, right? Is somebody cyanotic? Is somebody pale? Okay, we expect people not to have cyanosis. We expect people to have warm skin and flush skin, right? We look at the shape of the injury, okay, or the arm or leg, right? Is it a normal shape? In other words, is the arm straightened or is it at an angle like there could be a broken bone? And, you know, if you don't detect any injury, you could ask the patient to gently move, okay, whichever, you know, arm, leg, hand, or whatever, and see if there's any pain with movement, right? So that's what we kind of do. I mean, a lot of this stuff comes with experience, and you're not going to learn it, you know, how to do this listening to me teach you. This comes with experience, watching other people do it in time, to be honest with you. Okay, so when we're palpating, we're touching, right? So again, we're going to see maybe while looking at it, it looks all normal, but when you palpate down their arm, okay, you notice that something doesn't feel right. Okay. Again, the temperature of the skin, we expect the skin to be warm to the touch unless they're outside in freezing cold temperature. Texture, we don't usually worry about too much. In other words, that's how there's the feeling of the skin, smooth, rough, or whatever. That doesn't really pertain to us. And sensation is, do they feel us touching, right? So somebody who has a spinal cord injury, we said that besides being paralyzed, may have no sense of sensation, may not feel you touching them in different parts. Okay, when we're auscultating on a BLS level, the main thing that we auscultate for is what they call breath sounds. I have to just fix that slide. It's supposed to be 4. Okay, so the main thing that we auscultate from or for is breath sounds, right? So all we're listening to in a trauma patient, we're not listening, are they wheezing? We're not, because you know, they're not a medical patient. We're not expecting that this trauma patient's having an asthma attack. What we're really listening to is air going in and out of their lungs. So obviously the reason we're listening to air is their air going in and out of their lungs is, do they have a lung injury, right? So if they don't have if they do have a lung injury, it may be that only one lung is actually inflating and deflating, and we wouldn't hear the sounds, okay, of air going in and out. Remember, take your stethoscope, bother people for blood pressures, listen to their lungs, both old, young, healthy, not healthy, as many friends and family as you could bother, okay, to auscultate is the only way you will get good at it, you know, as far as learning the different sounds and, you know, feeling comfortable with your equipment and stuff like that. Okay, so looks like a couple people are having problems with their audio. So I don't know what's going on. Okay. Now, this term decap BTLS, right? So see, decap BTLS is basically what we call, you know, mnemonic, which is the first letter means something. And it's a way of helping us remember the types of injuries patients can have. So this is what we call soft tissue injuries. This is what we're really supposed to be doing tonight. So the D stands for deformities. In other words, does the arm not look straight? Does the leg not look straight? Contusions are basically collections of blood under the skin caused by what they call blunt trauma. Blunt trauma is that something hit them, didn't penetrate them. It caused a closed injury, but it ruptured the blood vessels under the skin and it was accumulating. Sometimes we would call that a bruise, right? So, but a bruise means it's already kind of changed the color. An abrasion is what you get when you fell onto the sidewalk and you scrape the outer layer of your skin off, okay? Punctures and penetrations would be like knife wounds, stab wounds, something actually entered to your body. Burns, I think everybody knows. And again, we're gonna have a night where we go through all this. Tenderness means it hurts when somebody touches it. Okay, laceration is the medical term for a cut. And swelling is what happens when, fluid collects under something. So usually with a contusion, there will be swelling because there's blood under the skin, right? So those are the things that make up DCAP BTLS. So remember, on the state exam, they could say to you, what does the D of DCAP BTLS mean? What is the A of DCAP BTLS? So you need to know what those different words are, okay, where they fit into the DCAP BTLS and what they actually are, right? Okay, so after we do our physical exam, we go into getting what we call a baseline set of vital signs. Again, this is the minor injured patient, not the severely injured patient. More than likely, we're doing this en route, okay? I'll tell you, in real life, people don't necessarily do everything in the order that you would learn it, in class. Some people may be talking to the patient and taking a set of vital signs at the same time. If you feel confident enough in your skills to be able to take an accurate set of vital signs and also remember what the patient's telling you, there's no problem with it, okay? But on the test, they would expect you to do your primary assessment, okay? If you're doing and then your secondary assessment en route, again, they're going to divide the secondary assessment between the minor injured patient, who we're just talking about, where you do a focused exam on their complaint, their broken leg, broken arm, whatever it is, okay, versus the seriously injured patient, where you have to do a complete assessment because you don't know what's going on. So right now we're talking about the patient with the minor injury. So after we do the physical exam, okay, which is very quick, right? They have a broken leg. We realize their leg's broken. We're probably going to start splinting it. Once we stabilize it and stuff like that, then we would get our baseline set of vitals, and we'd find out if they have any medical history. Now, for medical history, the acronym, or I'm sorry, the mnemonic they use is called SAMPLE. So it stands for signs and symptoms, allergies, medications, past medical history, last meal, and events leading up to it. And we'll go over this time and time again, okay? So SAMPLE is a way to help you just remember to take a history on a patient to find out what's wrong with them. So again, signs and symptoms of what's going on right now. Do you have any allergies? Do you take any medications? What's your past medical history? When did you eat last? And what happened leading up to this, okay? So it's just another mnemonic, just like APPU. Somebody emailed me today, just like DCAP BTLS that we just talked about. So again, sample, signs and symptoms, allergies, medications, past pertinent history, last time you ate, right? Last oral intake, and events leading up to the injury or illness. Just a thing to help you remember the questions to ask, okay? Then if the mechanism of injury indicates there's a possibility of having a cervical spine injury, remember cervical spine is the neck. Remember the vertebrae, right? We said there's 33 vertebrae that make up your spinal column. Your spinal column is the 33 bones, and running through the spinal column is your spinal cord, which is the major nerve that connects your brain to all the other nerves in your body. And remember that you have to remember, besides it's 33, that you have to know the divisions. So cervical is the neck, it has 7. Thoracic is the chest, it has 12. Okay, lumbar is the lower back, it has 5. Okay, and then sacral and coccyx are below the lower back, kind of where your butt is. And that's sacral has 5 and coccyx has 4. Okay, and the coccyx bone is kind of, and the sacral bone are all kind of fused together. They're not like little separate bones that the way we see the other ones are. Okay, and the spinal cord, right, the nerve does not go down all the way down to the very bottom, not even all the way to the bottom of the lumbar, like your lower back. I think it stops at like L3 or L4 or something like that. So it doesn't go all the way down. The nerve doesn't go all the way down, okay? So if we suspect a cervical injury, we would put a cervical collar on. Okay, they'll show you in class how to do that. You have to size it. They'll show you in class how to do that. This is just one way. It's kind of doesn't do it much justice. I'll tell you, in real life, cervical collars are eyeballed, which means that, you pick the one you think is right, you put it on. If it doesn't look like it's doing a good job holding the head, okay, you put on a different one. There is one size of the collar called no neck. I don't know how they ever thought of that name. But that seems to fit the vast majority of people for some reason. Okay, not kids, but the vast majority of adults. What they're trying to show you here is one way to size it is to put your hand really, not this hand would really be on their shoulder, and you'd see how many fingers it takes to get up to the jaw, and then you'd put that alongside the rigid part of the collar. It's a little hard to explain without actually having a collar, but they'll show you in class. But again, in real life, most people just eyeball it, think it's the right one, put it on, and as long as the head is stabilized, they leave it in place. If the head is flexed up or flexed down, then they would go to either the next larger or smaller size, okay? So again, we use a rigid cervical collar, okay? We slide it in place, and then we secure it with Velcro. Okay, so obviously if you're going to put a collar on, you have to examine the neck for injuries before you put it on because it'll be covered. Okay, you need to talk to the patient and explain to them what you're going to do. If it's a woman has, or I guess it could even be a man nowadays with earrings on, right? If it's the type of earrings that have posts, metal posts, that could be driven into their neck by the collar being put it on, you need to remove that. But remember, if you're removing it, you're giving it to the patient to hold on to, or a family member to hold on to, or even if the patient can remove it themselves. This way you're not responsible for it. Okay, you want to keep the patient basically their head and neck in a straight, the way it naturally is, so you're not flexing it or moving it. So that's what they call inline anatomical position. In other words, the way it normally would be. And then since they're sitting, you could bring the collar right up in front of them and put it in place. And then in class, we'll also show you how to put the collar when they're laying on their back. It's just a little, one extra tiny little step to put it in place. Okay. Now a collar, a cervical collar, doesn't really stop the head from moving. It's more or less a reminder to the patient that, you don't want them to move their head. So at some point, there has to be some better stabilization. Okay. Now, years ago, we used to tie them down onto the spine board that I showed you the other night, that long plastic or wooden board with straps. And then we used to tape their head, and we used to have cushions on either side of their head. And they found that really it does very little for spinal immobilization, because the behind your neck, right, is not touching the board, because the back of your head and your shoulders are touching the board. So the back of your neck is not. So that's really where your spine is. And that your whole back is not touching the board, because your shoulder blades and your butt are higher than your back is, so that your back was void. So what they found is that it was uncomfortable. People moved more, and it actually put their spine in more jeopardy. So now they just recommend getting the patient onto the regular padded ambulance stretcher, but using a collar, and then to have somebody just manually hold the head. Now, if you don't have enough people to be able to do that, you could always put some tape once they're on the stretcher. You could tape their head to the metal of the stretcher or something like that, just as a reminder, not to have the patient move their head. Now, some people think that spine boards cannot be used. Spine boards cannot be used to transport a patient to the hospital. In other words, patients do not go to the hospital on long spine boards, wooden or plastic spine boards anymore. But you can definitely use a spine board to help you extricate a patient from a car. In other words, you may need to slide the patient out from inside the car onto a spine board to help you get them out. Okay, or you may need it for movement or whatever it needs to be. So you can use a spine board, and we'll show you how to use it, but you don't transport the patient on it anymore. That's the big no-no, is transporting a patient to the hospital on the spine board. Again, it's very uncomfortable, and it does nothing for spinal stabilization. So that's why we don't transport a patient anymore on that. Okay, so again, maintain your spinal stabilization. And if it's a serious patient and you don't have ALS with you, you could always request to intercept them en route. You're not going to stay on the scene, okay, and wait for the paramedics to get there, because again, this is a trauma patient. Trauma patients have to be in the hospital as quick as possible. So you can request that they intercept you en route to the hospital, okay? Okay, so now we're going to talk about a serious patient, okay, who has multi-system trauma, right? In other words, this is a patient that's been injured. So we don't worry about a focused exam, because this is somebody who's been seriously injured. They probably have multiple. So we're going to do what's called a rapid trauma assessment. A rapid trauma assessment is kind of a expanded primary assessment, okay, where you're going to check them in a little more detail than you did, okay, than you did during your primary assessment, okay. So this should really actually say, well, okay, so here it says should be performed at the scene. I don't know that I necessarily agree with that, but I don't want to, not tell you what they're telling you in the book and stuff like that. Okay, now a rapid trauma assessment is a head to toe. You start at the head, you work your way down to the feet. This is, again, after you've done the primary assessment. So in my mind, I would get going. Like, you really, primary assessment, life-threatening injuries, you treat them as you find them, and then you go, right? And you may even do your whole primary assessment in the ambulance. If the ambulance is there at the same time as you, put the patient in the ambulance and do everything en route in real life. Okay, but here they're saying that you would do it, but they're saying the care that you would perform, okay, would be en route. So that's different from the primary, where in the primary, right, we treat them in the order that we find it. Here they're saying, okay, you perform it at the scene, but whatever you decide you need to do for the patient, you do en route. That's why I kind of think it doesn't really make much sense. And in all honesty, if you had a seriously ill patient, because now we're talking about a bad trauma patient, we're not talking about the patient with the minor injury, you would not be staying on the scene in real life. Like, if you did that, everybody else who had more experience than you would be yelling at you, come on, let's go. So might be the way they're teaching it in the book, but in real life, you got somebody hit by a car, thrown 20 feet, unconscious, bleeding, barely breathing. You're going to basically scoop them up and probably do your primary assessment en route to the hospital and treat whatever you can treat en route to the hospital. You'll probably never get to a set of vital signs because, you know, they're so unstable and you have to do so many things to manage them. Okay, so your rapid trauma assessment again is a head to toe. So you're basically looking at the body from the head to toe to see if you could find any injuries, right? So they're saying palpate or feel the skull, that's the cranium, the face, the ears, the nose, the mouth. Okay, at the same time, you're going to be looking right in the ears, okay, and in the nose to see if there's any blood or cerebral spinal fluid leaking from there. We're talking about when we did anatomy and physiology, we said when somebody has a skull fracture to the base of their skull, it's called a basilar skull fracture, that they could have blood or cerebral spinal fluid leaking from the ears or the nose. Remember, cerebral spinal fluid is the fluid that bathes the brain, okay, and bathes the spinal cord. So if there's a fracture, it could actually leak out. And that was the early sign of a basilar skull fracture. The late sign was called raccoon's eyes, where they get black and blue under their eyes, okay, like somebody punched them, and they get bruising behind their ear that we call the mastoid process. Okay, and we said, if you remember with the basilar skull fracture, when we were learning the nasopharyngeal airways, we said that was a contraindication, a reason why we could not insert a nasal airway if we suspected somebody had a basilar skull fracture, okay? Then we're going to look at the neck. Again, before we put the collar on, we could also, you know, we should look at the neck, right? So we're looking, is there any problems? Are there any wounds? The jugular veins are the big veins on the neck that empty blood back down towards the heart. They should not be visible, okay? If they are visible, it means there's some problem with blood flowing downward, okay, from the brain, okay, from the head down to the right atrium, right? Okay, do they have a stoma or tracheostomy, which is the surgical opening on their neck to breathe through? Okay, very rare, okay, especially for a trauma patient, right? Somebody who's trached is usually not going to be a trauma patient unless they were in an ambulance ride and got into a wreck or something like that. Okay, then we're going to auscultate with our stethoscope their breath sounds, okay? So we want to make sure they have what they call bilateral. So lateral means the side, bilateral means both sides, that they have bilateral breath sounds, okay? So you have patient breathe in, breathe out, go to the other side, breathe in, breathe out. Okay. Then we're going to palpate and look at the chest and see that it's rising and falling symmetrically, which means equally. Okay. And if we did not put a collar on yet, again, we're in a different assessment. We weren't in that first patient. We're in a different patient now, right? So we would apply a cervical collar. We again want to look at the chest, make sure it's moving up and down normally. Paradoxical motion means that the chest is not rising and falling equally. So we'll talk about that a little more when we do the different chest injuries, trauma chest injuries and stuff like that. Crepitation is the sound that bones make when they're rubbing up against each other. You should never hear that, right? It only happens with broken bones. And that do they have air coming in and out of their chest? And to be able to look at their chest, you have to expose their chest, right? So you have to, if it's a trauma patient, you have to cut their clothing off to be able to assess them. In the belly or abdomen, okay, we want to look at and see, is the belly flat? We're going to palpate it, make sure it's not rigid, okay? Again, in a trauma patient, we're not going to really look at pulsating masks, but we do medical emergencies, we're going to talk about a condition called an abdominal aortic aneurysm. So abdominal means the belly. Aortic is the aorta, right, that starts at your left ventricle, goes behind your heart, in front of your spine, and runs down to about the level of your belly button. So it's a huge artery, right? And if it has a medical problem, it can get a bulge in it, like a tire that has a, you know, a weakened area, and it's always a chance that it could rupture, okay? In the pelvic area, is there any trauma? Is there any bleeding? In a man, we also look at their penis to see if it's erect. And remember, we talked about somebody, when we're doing shock, we said there was a type of shock under distributive shock called a neurogenic shock or a spinal cord injury shock. And we said the definitive sign of that in a man is that they would get an erection, right? So there's a guy who fell off a roof and he's laying there and he has an erection, which would not be typical for somebody who just fell off a roof. And again, the neurogenic shock and actually all the distributive shocks, and we're going to review that next class, is caused by vasodilation. So because the shock is caused by blood vessels dilating and there's more blood going to his penis, he gets an erection, right? So that's a definite sign of somebody who has a spinal cord injury in a man, right? Now, I did send out a email, I think earlier in the week or maybe at the end of last week, where I basically wrote up a summary of all the shocks, okay? So it was like a quick way. And then I had sent out a series of little review audios, review lectures I did on all the different types of shock. So all that stuff is on Dropbox for pretty much everything in the class. There's tons of review material, you know, on Dropbox. So, you know, if you're falling behind or you're having a problem or something like that, something you don't understand, you could always look and see if there's something there, in addition to reaching out to me, okay? And then we want to examine the extremities. Okay, so is there any pain? Are the extremities, normal looking, or are they deformed? Again, we're going to compare them to the other side. Do they have a pulse? Okay, in every extremity, distal pulse. In the wrist, it would be the radials, or do they have good circulation in their fingers? Okay, in the feet, pretty much we usually just do capillary refill. Do they feel you're touching their fingers? Can they squeeze your hands? Can they push down with their feet like they're pushing on the gas pedals, right? So that's all sensation and motor function. So we just want to make sure that all the signals from the brain are getting to all the different extremities. And this will make more sense again when you're actually doing it, in the classroom on a patient, right? When you're doing it on one of your colleagues. So showing you how to palpate the abdomen. Remember, there's 4 quadrants. So now he's at the right upper quadrant, right under the ribs. Now he's got to do down here, right lower, okay, left lower, left upper. It doesn't matter the order that you do them. Okay, then you're going to look at the back, right? Posterior is the back. Make sure you always need to look on a trauma patient on the back, right? The last thing you want to find out is there's a serious injury on the back, prior to getting them, and it wouldn't be on the backboard. I have to change that. It wouldn't be on the backboard because, again, we would be transporting them to the hospital on a stretcher. It may be the backboard just to move the patient. Okay, and we'll show you how to roll a patient onto a board to move them, okay? And, we'll talk about all that, how patient movement and stuff like that. Again, remember your baseline set of vital signs is your first vital signs, okay, that you would use to compare other vital signs to. And the comparing of other vital signs is the term trending, okay, where you look at multiple sets of vital signs. Since we're talking about in this, little series of slides, a seriously ill trauma patient, again, they may have life-threatening injuries and you're never going to get a set of vital signs. You may even never get a second set of vital signs to compare the first set to. So that's fine. If the patient has so many life-threatening injuries that you're busy keeping them alive, that's totally acceptable, okay? And don't worry about it. It's known. I mean, again, when you get to the hospital, they may not be so on board with it, but don't worry about it. If you can't get a set of vital signs because you were bagging the patient or you were stopping bleeding or whatever it is, you don't have to really worry about it. Again, you're going to check their back and buttocks. Notice that they have somebody holding the guy's head in line with his spine, right? So you never want to roll a patient unless somebody's stabilizing and they're going to examine their back. If it was a really bad trauma patient, they would have also cut his pants off, his back, his buttocks, the back of his legs, and stuff like that, okay? Again, in all assessment, you always want to communicate with your patient if there's conscious and they can understand, okay? You need to take clothing off to be able to examine a patient, okay? You want to, have eye contact with your patient, reassure them, okay? Unless proven otherwise, you're always going to assume there's a spinal cord injury, although the incidents of spinal cord injury are pretty rare, okay? And if during your assessment, that's what they mean at the last line here. Okay, if they're saying stop or alter assessment process to provide care. So in other words, if during your assessment, now, in the primary assessment, you'll find it right away, right? Because you're treating things in the order that you find them. But in your secondary assessment or your rapid trauma assessment, if you do find something wrong, it's going to do the same thing. You're going to stop and manage that before you move on to anything else with that patient. Okay. So just showing you some things here. They're assessing for a pulse, which would be circulation in the patient. They could ask the patient what finger they're touching. Okay. And they could ask the patient to move their fingers. And then you would do, that would be considered circulation. Motion, right? They're moving their fingers. And sensation, what finger am I touching? Okay, so here's motion, okay, and sensation. The only thing I would say about giving patients your 2 fingers, people do it. And if it's a nice, upright, kind person's fine. But if you're dealing with a drunk or somebody who doesn't look like they're so nice, if you give them your 2 fingers, they basically control you, right? I mean, they bend your fingers if they're not nice, or they're a drunk or they're an idiot. So I don't give patients 2 fingers. I usually give them the palms of my hand and tell them to squeeze my hand, because you have a little more strength then. And the reason you do both simultaneously is that you want to see if there's a difference in the strengths, okay, from one side to another in the patient. Okay. Now they're showing you a pulse site, right, to check in their feet. That's called the posterior tibial pulse, okay, over here. And there's a dorsalis pedis pulse, over here on the arch of the foot. So there's different pulses. Most people just usually look for capillary refill. And in all honesty, I can't remember the last time I've checked for a pulse in somebody's foot just because they're a trauma patient, unless they had a fracture on their leg, right? Usually if there's a fracture on the leg, we would look, but Just because somebody says, I broke my arm, we're not going to really look in their feet to see if there's any problem with circulation. Okay, on pediatric side, right? So just remember that it doesn't take as much to injure them, right? Their bodies are softer, their bones are not hard, they don't have as much muscle, right? So, a minor mechanism of injury where it may not hurt you as an adult may injure a child. Okay, and with kids, obviously they're petrified, they're scared. So as much as possible, try to have communication, have the parents present and stuff like that, not to frighten them. Okay, so it says, what criteria would you use to decide whether to perform a focused physical exam or a rapid trauma exam? So again, the focused physical exam is somebody who has a minor injury. They broke their arm, they broke their leg, right? A minor injury. And a rapid trauma assessment is on a patient who has a serious injuries. They were struck by a car, they fell from a great height, whatever it's going to be. And you have to check their whole body. So focused means you're focusing on one specific problem. If a patient has 3 complaints or 3 injuries, they're not getting a focused, they're getting a rapid, right? So that's the difference. Okay, so again, a focused is a single injury and you're focusing on that, where a rapid trauma exam is the whole body. Now, the next step is doing what they call a detailed physical exam. Now, this is again the book. So this means we've now examined the patient. This will be our 3rd time looking at the patient. So in Rockland County, we don't even have time probably to get to the secondary. But now they're saying that you would do another physical exam. Okay, so this one absolutely would only be done en route to the hospital. And you're going to see there's even one more exam after that. So this is all book knowledge. It's not really real life, to a patient. Okay, so it says gathers additional information from the patient. Complements means it adds to the primary and secondary because we've already completed that. Okay, it's only performed after all life-threatening, all life-saving interventions, all the care that you render to the patient is done. Okay, and what does it say? Primary assessment reevaluated again. Remember, I told you on the test, there are going to be a couple questions on primary assessment. That's what they really, focus on the exam. They're going to say, what is the purpose of the primary assessment? And that is to find and treat life-threatening injuries in the order that you find them. Then they're going to say, what is the first thing you do if a patient that was stable in the ambulance becomes unstable? So you were taking a patient to the hospital, everything was fine, and all of a sudden something goes wrong. And the answer is going to be to repeat the primary assessment so you could figure out what their life-threatening problem is and treat it in the order that you find it. Then here you see in the detailed physical exam, they say, what's the first thing you do to complete a detailed physical exam? It's repeat the primary assessment. Okay, so it always goes back to primary assessment because that's where you find and treat life-threatening injuries. Okay, so again, trauma patient with significant injury. Okay, it says that for these patients, you would have assessed the entire body during the rapid trauma assessment, which is what we were just talking about before. Okay, so now, okay, you would reassess the patient, okay, slower and more thoroughly. But again, if they're a serious trauma patient, right, you're trying to keep them alive. That's what I'm trying to get at. Like sometimes the people that write this material have been so removed from real patient care that they're not thinking of what would really be done in real life. Okay. So somebody asked me, is this for a rapid trauma patient only? I would say yes. I would say that you're not going to really be doing a detailed physical exam on somebody with a broken arm because again, you did a focused exam. So there really wouldn't be any reason to go and check their whole body over again another time. Okay, so this would be more for the patient who had the rapid trauma, assessment and stuff like that. Okay, so when we examine them, we're examining them slower in a little more detail. Okay, again, we only do this after we have saved the patient, right? This is a patient who, is totally stable and we can go to the hospital and we could spend a little more time looking at them. Okay, it says if you're treating a severely injured patient or too busy to complete the detailed exam, it is not a failure. In other words, most people would never get this done if they were a seriously injured trauma patient because you're too busy keeping them alive, right? Okay, so we want to expose the patient. Obviously, they may have some collars on or different types of, splinting and stuff. So you're not going to loosen that. You're just going to work around it, okay? And the components of the detailed physical exam were exactly the same as what we just talked in the rapid trauma assessment, which is that you go head to toe, except you go a little slower and a little more detail. Real life, nobody's doing this, right? In other words, your primary assessment, your rapid trauma assessment, your detailed physical exam are all basically reassessment, all that are all basically accomplished simultaneously. On the scene, it's the rapid trauma assessment. En route, you're just continuing off that assessment and trying to stabilize the patient. So on a test, they may ask this kind of stuff. Okay, so again, trauma patient is not seriously injured, does not need this detailed physical exam. Okay, but always be suspicious that there may be something you missed, right? So I mean, don't look at a patient all the way to the hospital and say my job is done, right? You're always constantly saying, let me know if anything changes, let me know if anything starts to hurt, let me know if you start feeling weak or dizzy, so that you always, can not develop that tunnel vision and assume that everything's fine. Okay, and as being a good person, remember people are scared, they're not used to being in the back of ambulances, so they may need some reassurance. It's called psychological first aid, right? You need to reassure them. I don't ever really tell anybody everything's going to be okay, because you don't really want to say that to somebody and then they go and something terrible happens to them and they turn to you and say, well, you said everything was going to be okay. So I usually say, right now, I don't see anything seriously wrong with you. Okay, but we're going to get you to the hospital to have you checked out by some doctors, and they'll do some x-rays and maybe a CAT scan, and they'll be able to better, see what's going on with you. So I never tell them, don't worry about it. You're fine. Nothing bad is going to happen to you. Okay. Okay, so we said here, is it always necessary to complete a detailed assessment on a trauma patient with no significant mechanism of injury? Okay, so no, right? I mean, if you have a patient, again, with a focused injury, you don't need to examine every single part of their body unless you think you may have missed something, and then you can, okay? Okay, the patient without significant mechanism of injury receives a history of present illness and physical exam focused on the area. So that's the patient with the broken arm, right? The minor injury. So we go over and we do a focused exam on that injury, okay? And we manage, whatever their minor injury is, okay? After that, we do the baseline vitals and a history. Okay, for the patient who has a significant injury, right? So they're seriously hurt, okay? We would now go on to doing our rapid trauma assessment. Okay, we would consider the possibility of getting ALS on the scene. Okay, if you can find out a little bit about their medical history. Okay, and again, that rapid trauma assessment is the important thing. The rapid trauma assessment is a more detailed primary assessment. Okay, I would say should be done en route. Okay, I don't think you should ever stay on the scene to do it, but your book did say you could stay on the scene to do it. Okay, but we would go through and look, okay, as kind of a more detailed primary assessment or initial assessment on the patient, looking for any life-threatening injuries and stuff like that, okay? All life-saving interventions, all like patient care management should be en route, okay? And then once you stabilize that patient and made them better, you could do that detailed physical exam, but it's not gonna happen in Rockland County, we're too quick. Okay, so again, the detailed physical exam is the same as the rapid trauma assessment, but you just go slower and a little more detail, okay? The detailed physical exam does not take place at the scene, right? It's always going to be en route. And I would say, again, if it's a seriously injured trauma patient, all your assessments are going to be done en route, right? If you have an ambulance available, it'll take you 30 seconds to pick the patient up off the ground, put them on a stretcher, put them in the ambulance, and start going to the hospital and managing them. That is what you will see done, okay, if somebody was struck by a car, even if they're conscious, if the ambulance is available, right? In other words, that you didn't first respond to the scene and you don't have the ambulance with you. Okay, the detailed physical exam is most appropriate with a trauma patient who is unresponsive and has a significant injury or unknown. So that is not true. Okay, in other words, you're not going to do a detailed physical exam on that patient, right, who has serious injuries, because you're going to be managing them en route to the hospital. Okay, if the patient's minor, right, they're awake, okay, then you're probably not going to do a detailed physical exam, because you're going to do the focused exam on them. And then the last step of assessment, which is, again, we're never going to get to in Rockland County, is reassessment. So now you're on your fourth assessment of this patient. So you can tell this has kind of been written by somebody who doesn't really take care of patients, or somebody who lives 50 miles from a hospital, okay? So it continues on the initial steps of assessment. The first part of reassessment, okay, is the primary assessment, okay? So where does it say here? So again, the first part of reassessment is to repeat the primary assessment, okay? And that's where we're going to look for life-threatening injuries and just make sure there's nothing we missed, okay? So, so really reassessment, I don't know how to, without making it sound like this is totally bogus. You have a really seriously injured patient. You pull up, you are the crew on the ambulance. You pull up, you're going to jump out, okay? You're going to pick the patient up, put them on the stretcher, probably apply a collar before you do that, okay? Gently put them on the stretcher, load them in the ambulance, and get going to the hospital. En route, you're going to do your primary assessment, and whatever you find wrong with them, you're going to fix en route to the hospital. In Rockland County, with the exception of maybe North Rockland, Haverstraw, Stony Point, or maybe the bottom of Chestnut Ridge or the furthest part of Sloatsburg, you're probably going to be at a hospital in 5 to 6 minutes. Okay. So you're never going to have time to run through all this stuff. This is more or less just for the test. Okay. On the test, just remember, if they tell you the patient has a broken arm, what type of exam do you need to do? It's called a focused physical exam, which means you focus on the injury. Other than that, if they tell you the patient's unconscious or they have a serious injury, then you're going to be doing your, your rapid trauma assessment, where you're going to, it's basically an expanded primary assessment, but still it's done en route, and you're going to treat injuries in the order that you find them. Okay. Now, if they have to do a question on reassessment, it's always what is the first thing you do in reassessment, and the first thing you do in the reassessment stage is repeat your primary assessment. If they ask you any question on assessment and they say what's the first thing you do, just look and see if there's something that says repeat primary assessment, and that is probably the right answer, because they're real big on that. Okay, pediatric wise, okay, so obviously if you have an unresponsive child or infant, okay, that is a seriously, seriously ill child. Okay, so you want to see if you can, wake them up. So remember, your AVPU is your mental status: alert, verbal, painful, or unresponsive. So alert means that when you got there, that patient was awake, talking to you, and made sense. That's a little more difficult to assess in a baby, right? So a baby, we look to see if they recognize their parents and stuff like that. Okay, verbal would mean that they were unresponsive when you got there, but by talking, calling to them, they woke up. Okay, painful means they didn't respond to, they were unconscious when you got there, they didn't respond to verbal stimuli, but you did something that was painful to them and they woke up. Okay, and then the last thing is that no matter what you did, you cannot get them up. Now, if they are a V or a P, right? So if they're alert, okay, we need to assess, are they oriented? If they're verbal, we need to assess if they're oriented. And if they respond to painful stimuli, we need to assess if they're oriented. So oriented means that they know who they are, where they are, and what's going on. So sometimes people say person, place, and event. So person is who they are, place is where they are, and event is what's going on. So it's not enough to see that, say that somebody was, we woke them up by calling to them. They're also going to want to know that when you woke them up, how were they? Were they 100%? Would they know everything was going on? Were they with it? Or were they slow to answer, confused? They didn't know where they were. They don't know what happened, right? It makes a big difference, okay? And obviously in pediatric patients, crying is a normal response to any kind of trauma situation. Okay, in the reassessment, if we take multiple sets of vital signs, we can compare them with the baseline. That's called trending. If we use the pulse oximetry, we can look at their oxygen saturation. Again, we're probably not going to have time to document the whole lot because we're taking care of the patient. Document means to record it on the computer or on your written PCR, okay? And you're going to go through, if you have time to do a reassessment, you're going to repeat your history, what's wrong with the patient, and your physical exam. Okay, you're going to look at what you've done for the patient. In other words, if you put them on oxygen, did the pulse ox improve? If you put a tourniquet on them, has the bleeding stopped, right? So this is all common sense stuff that we'd be doing, automatically. We don't have to wait for the reassessment stage to do that. Now, trending, again, is where we said we look at multiple sets of vital signs, okay, and see if there's any change from the first set of vital signs. But the problem, again, on a seriously ill trauma patient is that we're not going to probably have time to get multiple sets of vital signs. We may not even get time to take the first set of vital signs. And also because of where we live, that our transport time is so short that we may not actually have enough time to get multiple sets of vital signs, okay? Okay, reassessment for the stable and unstable patients, okay? So, on the test, they're going to say that you should be basically reassessing a seriously ill trauma patient every 5 minutes and a stable patient every 10 minutes. Oh, here it says 15 minutes. So again, the 15 minutes on a stable patient is fine, except that most of our transports don't even last 15 minutes, but let's, take that out of the equation. Taking, we're taking another set of vital signs or reassessing a patient, if you had a long transport, that's fine. I don't know if I would do it every 15 minutes, probably be annoying to them, but maybe every 30 minutes. But now there's 5 minutes for the unstable or potentially unstable. The problem is, again, if they're unstable, you're doing things to try to make them stable, and taking their blood pressure is not going to make them stable. Stopping bleeding, getting them on oxygen, suctioning their airway, right, positioning their airway, those are things that are going to save people's lives. Taking their blood pressure every 5 minutes is not going to save their lives. Okay, so on the test, you would answer that, but in real life, if you said, as you're taking the seriously ill patient to the trauma center, oh, I need to get another set of vital signs, so I'm not going to bag them, I'm not going to ventilate them, I'm not going to suction them, people would look at you like you're crazy. So just again, on the test, every 5 minutes for an unstable patient, every 15 minutes for a stable patient, okay? And if you think something changed, remember I said there's going to be a test question that your somewhat stable patient, okay, all of a sudden got unstable. What's the first thing you do? It's always going to be to repeat the primary assessment. And I think last month's Shabbos, we saw that on one of the test questions. Okay, so any questions on the physical exam or anything like that? Okay. So let me find what we're supposed to do. And so it's 8:50. We'll go till 9:30, then we'll take a little bit of a break. Okay, what's going on? Okay.
Thank you.
Mm-hmm.
I was just wondering, we're talking about the trauma. If someone gets hurt on the back or they break the skull,
Mm-hmm.
and is there any time where a patient can't be laying on the back on the stretcher?
So I had one time somebody that had big shards of glass. They went through a windshield, and they had big shards of glass stuck in their back. So obviously we couldn't put them on their back. So the problem is you can't manage someone's airway if they're not on their back. So you do have to get them on their back. So what we had to do was, pull those pieces of glass out of them, even though technically we don't really remove things that are penetrating the body, but there was no way of managing that guy's airway. Short of that, I would really only be if there's something to prevent you from rolling them on their back. So again, I don't know, a piece of wood stuck in them, a knife stuck in them. But again, you might be able to manage them on their side somewhat, but if they need to be ventilated, if they're not breathing, we can't ventilate patients on their side. So you would probably have to try to, as best you can, to remove it, or try as best you can to ventilate them when they're on their side. But it would be difficult. But fortunately, it doesn't happen, that often. Okay, so everybody, I assume, can see chapter 25, bleeding and shock, right? So the first thing is quick review of the circulatory system, right? So we know the circulatory system is made up of the pump, which is the heart, right? The heart has 4 chambers, 2 atriums, 2 ventricles. The atriums don't do much other than hold blood before it goes down to the ventricles. The right ventricle pumps to the lungs. The left ventricle pumps into the aorta to the whole body. The left ventricle is the biggest, strongest part of your heart. The tubes are called arteries, veins, and capillaries. Arteries always leave the heart and are high in oxygen, with the exception of the pulmonary artery. Okay, the pulmonary artery starts on the right ventricle. So since it's getting the deoxygenated or blue blood, right, the used up blood from the body, it's only called an artery because it's pumping away. So it's pumping to the lungs, so it's low in oxygen. And the pulmonary vein, which brings blood back from the lungs to the left atrium, is the one that's high, the only vein that's high in oxygen. And between a artery and a vein, that's what they're showing you here, is a capillary network, right? So basically the arteries come into smaller arteries, and then come into a series of what they call a capillary bed. You can kind of make it out over here. Okay, and then the capillary bed is where all perfusion takes place. Perfusion is the feeding of the cells, is the giving of the cells of the oxygen and the nutrients, the food that it needs to stay alive, okay? And then it takes the bad stuff, the waste products, okay, the carbon dioxide, the lactic acid, all the waste products back, okay, away from the cells, and brings it to either the lungs or the liver or the spleen or the kidneys to get cleaned up, okay? And then it goes back to the heart and starts the circulation all over again. So again, arteries, veins, and capillaries. If they ask you what blood vessel perfusion takes place in, it's a capillary. If they ask you what blood vessel is usually high in oxygen, it's an artery. If they ask you what blood vessel is usually low in oxygen, it's a vein, again, with the exception of the pulmonary vessels. And then obviously the fluid is the blood. And we said that we have a couple of different components of the blood. We have the fluid portion of the blood, which is the plasma, and floating in the plasma, okay, is the cells, the red blood cells, white blood cells, and platelets. The red blood cells have a protein called hemoglobin. That is what the oxygen gets carried into the cells by. The white blood cells fight infection, and the platelets play a role in bleeding control. Okay, so again, heart, blood vessels, and blood. We said arteries carry blood away from the heart. Okay, arteries are thicker because they have to handle higher pressure, right? And arteries have the ability to dilate and constrict depending on where the body needs to send blood to, right? Capillaries are tiny, tiny blood vessels that you cannot see without a microscope. but they are the most important blood vessels. They are the only blood vessels that let things in and out of them. So those are the ones that provide the perfusion or nourishment to the cells, okay? So, so it says the kidneys filtered blood. Somebody wrote a question, filtered blood on the way back to the heart or both ways. So it would be, blood would go to the kidneys from the heart pumping. So in other words, it would be an artery that goes into a kidney. So the blood would have flown, the used up blood would have flowed through the heart, okay, and then go to the kidneys to get cleaned off. So it would pass through the heart one time with the garbage inside of it to get to the kidneys. It's called your renal arteries, or the arteries that bring the blood to the kidneys, to everything. I mean, in other words, an artery is always going to the organ, okay, and then a vein is bringing it away from the organ to be recirculated to where it needs to go. Okay, so again, capillaries are the thinnest walled vessels, microscopic, and they usually are pressed right up against the cells that need what they have. And everything that leaves a capillary is good, and everything that goes back into a capillary is usually bad. So in other words, if there's sugar in a capillary and the cell needs it, the sugar will cross out of the capillary because the amount of sugar is higher in the capillary than in the cell. It'll cross over into the cell will use it. Okay, and the same thing if there's a lot of carbon dioxide in the cell, but little carbon dioxide in the capillary, it'll cross over. So everything always goes from a level of high to a level of low. And you know, it just depends on whether it's needed or not needed, and whether it gets rid of it or carries it. Okay, and then veins bring that used up blood back to the heart, okay, so that it could be either dealt with in the lungs or dealt with in some of the other organs. And because the pressure in veins are so low, they have a series of valves, so the blood kind of goes in stages and it can't go backwards. They're like check valves, so the blood can only go in, you know, say 6-inch increments through veins, especially the veins in your legs, because if you're standing up, it's so hard for that blood to circulate back to your heart because the pressure in veins is low because it's the end of circulation. Okay, and then we said the blood has multiple functions, right? So hemoglobin transports both oxygen and carbon dioxide, okay, around in your blood to either bring it to the cells or get rid of it out of the body. Nutrition is the food or the feeding. We mainly talk about sugar, but there's obviously other things, vitamins and minerals and stuff like that in the food. Excretion is the getting rid of the bad stuff, right? So you excrete it by urinating it, you're excreting it by having a bowel movement, okay, or exhaling it. Okay, protection is fighting infection, okay? And regulation is controlling, let's say, temperature, right? So we can control our temperature somewhat by either circulating warm blood, okay, to the surface to get rid of heat, or conserving warm blood inside our body to conserve heat and stuff like that. Okay, most adults have about 5,000 to 6,000 milliliters of blood, and they abbreviate that 5 to 6 liters. Every 1 liter is 1,000 milliliters. Okay, so 5,000 would be the same as 5 liters. 5,000 milliliters would be the same as 5 liters. Okay, obviously the bigger you are, the more blood you have. Okay, and men tend to have more blood than women do. Okay, obviously children have less blood. I don't know if there's an actual formula by weight of how you figure out approximately how much blood a child has or anything like that, but you know, just to realize a kid with a nosebleed can get, I don't want to say shocky, but can definitely, it could be more serious because they don't have extra blood, right? We have extra blood in our body. You know, at any given time, your spleen has about a half a liter of blood sitting in there. So, you know, it just is extra blood. So the kids don't have that reserve of blood. So kids can definitely run into problems. You know, you have a kid who falls down and cuts their scalp, right? Cuts the skin over their skull. Well, the scalp is very, very vascular. So that means there's lots and lots of blood vessels. And that is to provide a temperature control between the cold outside air and your brain, right? So it has this warm blood that's circulating, okay, across your skin to try to prevent, when you go outside, to prevent your brain from cooling and stuff like that. So somebody who has a cut on their skull can be bleeding very severely, but it's typically a tiny little cut. So it's just a matter of finding the blood vessel that is bleeding and putting some pressure on it. So sometimes we actually have to just take some water, you know, we carry bottles of sterile water on the ambulance and pour it on their head, wash the blood away and see where the bleeding's starting from again. And then usually with one finger, you could hold some direct pressure with a gauze pad and stop the bleeding. But kids, okay, can suffer from even the most minor bleeding because they don't have a reserve of blood in their body. Okay, we said perfusion is the feeding of the cells, and that requires there be adequate circulation of blood to all the cells, right? It also requires that the blood has the good things in it, right? So we talked about, like in carbon monoxide poisoning, there's plenty of oxygen, okay, in the blood, but it can't get into the cells because of the carbon monoxide blocking it from getting on the hemoglobin. So in the blood, there's plenty of oxygen, which is why using a pulse ox is useless. But in the cells, they're starving for the oxygen because it needs the hemoglobin to bring it in. And the hemoglobin doesn't have it. So there's different ways that people can have lack of perfusion. The term hypo means low. So hypoperfusion means there's not enough or inadequate perfusion. So the cells are dying. And that is what shock is, right? And we have to figure out which of the categories of shock it is, and is it something that we can manage? So we had multiple categories, right? We had hypovolemic shock that we divided between hemorrhagic, which is bleeding, and metabolic, which is like vomiting and diarrhea, where you're losing fluid other than blood. We had cardiogenic shock, where there's a problem with the pumping action of the heart, or a problem with the valves that make the blood go in the right direction, or a problem where fluid is filling up the pericardial sac, the sac that the heart sits in, and squeezing the heart. We had distributive shock, which is where the small blood vessels suddenly dilate. We said there's 4 kinds of distributive shock. There is neurogenic, which was the spinal cord injury. There is sepsis, which is the massive body infection. There's anaphylaxis, which is the severe life-threatening infection. And then there's the vasovagal, or the psychogenic shock, where somebody sees blood or gets bad news and their blood vessels suddenly dilate. The reason you're going into shock is not that you're losing blood into distributive shocks. It's that the blood vessels dilate, so the pressure falls because the space inside the blood vessels is bigger. And then we had the obstructive shock, which are typically large blood vessels. They get blocked. And we talked about pulmonary embolism, tension pneumothorax, and so on. So we'll have to, review that time and time again. Okay, so bleeding is, the term for blood leaving the blood vessels, but the medical term for bleeding is called hemorrhage. Okay, so hemorrhage is bleeding that is significant enough that people are going to call the ambulance or go to the hospital. Okay, so the type of shock that occurs, okay, from bleeding is called hemorrhagic shock or bleeding shock, right? So we know that people can have external bleeding, which we could do a pretty good job of managing with direct pressure and hemostatic gauze and tourniquets, or they could have internal bleeding, which we could do nothing to manage other than put them on oxygen, keep them warm, and get them to the right hospital as quick as possible, okay? We know that bleeding from an artery is bright red and spurting. It's bright red because there's oxygen, more oxygen in it, and it's spurting with each pulse, right? So it's getting shot out of the body, and people can bleed to death very quickly with arterial bleeding. Veins tend to be a darker red because there's not a lot of oxygen, and it flows steadily like you were turning, the faucet on slowly. People can bleed to death from veins, not quite as quick as an artery, but they definitely can if they sever a large enough vein. But veins are easy to control the bleeding, much easier than an artery, because an artery, it keeps on spurting and breaking down any clotting that the body's trying to get on it. And most of us have only seen capillary bleeding, where it basically kind of oozes up to the top and then flows by gravity towards the floor, right? And that's very easy to control. You just put some direct pressure, okay, and it stops the bleeding. Usually takes within 30 seconds, you can stop most capillary bleeding, unless you're on blood thinners or something like that. Okay, so the term for a cut, the medical term for a cut is called laceration. So they say lacerates or destroys the blood vessels underneath, okay? And, again, external bleeding is visible on the skin. And whether or not it's serious or not depends on the type of wound, the type of blood vessel that's cut, and does the patient have any medications on board. They're going to interfere with their ability to clot the wound or close the wound, right? So if they're on blood thinners, aspirin, or anything like that. Again, we said arterial bleeding is bright red, spurts with the heartbeat, oxygen rich, and it's definitely the hardest to control, especially if it's not on an extremity, because it's very hard to, wait. If it's on an extremity, you can put a tourniquet on it if worse comes to worse and shut off blood flow to the site of the bleeding, and then you're going to control the bleeding. Okay, venous, we said, is darker color, tends to flow because it's under less pressure. But again, a large vein, you could bleed to death, not quite as quick as a large artery, but definitely you could bleed to death if nothing's done. And then capillary bleeding, okay, is very slow bleeding. It's about as bright red as a arterial bleed is, but it's not spurting. It's kind of just dripping or oozing to the surface. And you've all seen capillary bleeding. Okay, so what can make bleeding worse is, again, the prescription medications that interfere with a patient's ability to form a clot, right? So those are blood thinners, those are aspirins and stuff like that. The colder a patient is, the harder it is for the blood to clot. So we definitely want in trauma patients to get them off the cold ground, to wrap them up. I know we may have to cut their clothing off to examine them, but as quick as possible, we need to wrap them up and try to keep them warm, Okay, remember, because bleeding can carry disease, we need to use our standard precautions, gloves, goggles, and so on. Okay, and just like every patient, we want to ensure an open airway and adequate breathing. But let me ask you, you have somebody with arterial bleeding, okay, and they're not breathing. So you have somebody who's not breathing, but they have arterial bleeding. I think we talked about this the other night. So if you follow the primary assessment, airway, breathing, circulation, you would be managing the airway before you'd ever worry about the bleeding. Now, if you have 10 people there, you could assign people to do everything, right? You could say, okay, you manage the airway, you do the bleeding. But let's say it's just you and your partner, right? Two of you. So you may have to not worry about the airway in real life, okay? And you may have to stop the bleeding, right? Just throw a tourniquet. You wouldn't even try direct pressure. Just throw a tourniquet on this guy and then go back to the airway, because think about it. If they're losing all their blood, okay, there's not going to be any ability to carry oxygen, right, in the bloodstream. So if you're worried about ventilating them, but yet there's no way of that oxygen to transport through the body because they're losing all their blood, it would defeat the purpose. So on the test, airway, breathing, circulation, but in real life, you may have to say to yourself, okay, you know, I'm going to have to get that tourniquet on them first, and then I'm going to worry about going to ventilate them. Okay. Okay, so again, it says control bleeding only assessing and treating prior elements. That's talking about A, B, C, D, E, right? Because on the test, you're going to say you're going to treat things in the order that you find them. But again, in real life, you may have to use common sense and modify things. And that just comes, you know, with your ability to do a good assessment, and that you know, this is not going to be something the day you get out of class. This is going to be something that takes months, if not years, to develop, depending on how fast, how busy or slow a system you work in, right? If you're working in a place where, you know, you get one call a week, it's going to take you years to develop that sense of skills. If you're working in a system where you're going on 3, 4, 5 calls a day, you know, it may take you only a couple of months to develop that system. Okay, so again, if it's external bleeding, okay, we can use a combination of direct pressure. We don't do elevation anymore. That's been taken out of the protocol. That was kind of elevating the limb to help gravity, you know, have gravity help you stop bleeding. They found that it really didn't accomplish much other than making the blood hit the ceiling easier and stuff like that. So we don't really worry about that type of stuff anymore. Okay, so direct pressure means that with your gloved hand, okay, you're going to press down on the wound, hopefully having some type of, you know, gauze pad or something like that. But if all you have is a towel or your shirt or whatever, you'd use whatever you have. A hemostatic agent is a bleeding control agent that's designed, has chemicals on it to help the body stop bleeding. And obviously a tourniquet is some type of device that will be circumferential around the arm or around the leg and put pressure to actually cut blood flow off. And we'll look at all of those. So again, direct pressure, whatever you have. Okay, obviously you should have your personal protective equipment on and stuff like that. Okay, and you want to hold it in place until the bleeding is controlled. Okay. Once you have stopped the bleeding, then we put what's called a pressure dressing over it. So typically we use roller gauze or cling, and we wrap it around tightly to hold pressure on it. Okay. And you don't want to ever remove any dressings that are in place in this situation if you're just using regular gauze, because that will break down whatever clots developed. Okay. And then after you have stopped the bleeding, okay, you may have put it on so tight that it actually is almost like a tourniquet. So if the person says to you, I feel like there's pins and needles in my hand, okay, but the bleeding is controlled, you may have to take, you know, a second and try to loosen it or unwrap it a little bit, okay, to see if you can reestablish blood flow if you put it on that tight. Okay, but again, you don't want to start the bleeding again. So you have to pay attention that, you know, if you needed to have on tight, that the fact, you know, so tight that he's getting pins and needles because that's the only thing that stops the bleeding, then that's what you're going to have to actually do. But most of the times, within a couple of minutes of the bleeding stopping, a clot has started to develop, so you can actually back off the pressure a little bit. Okay, so we'll practice bleeding control. Okay, go ahead. Somebody a question?
I'd like to go back to and cause a stroke or heart attack.
I'm sorry?
Can a clot formed by a wound go back and cause a heart attack?
So it won't cause a heart attack. It's the two things it could cause would be a pulmonary embolism, which is a blood clot in the lung. Okay, and that's probably what it would cause, because again, the first place that venous blood, so the place that you're probably going to get a clot is not in an artery. Okay, because an artery is flowing with a lot of pressure, so you know the blood doesn't stay still long enough for it to clot. It's the veins that you have to worry about, right? So veins are always going back to the right side of the heart. And the first place it could lodge after it passes through the right atrium and the right ventricle is the lungs. So typically people would have the problem in the lungs. I used to say I don't think that's really so likely, but we had a young lady probably 20-something-year-old lady. It was doing one of these like high endurance types of races, you know, where they jump over things and they're, you know, it's very, very intense. It's called an Ironman. And she fell very hard. Okay, she tripped and fell and got a huge bruise on her thigh, right? So she got a big black and blue on her thigh. And whatever, she was out of the race. The ambulance evaluated her. She didn't want to go to the hospital, and she basically, you know, kind of limped off and went home. And come to find out that, you know, the following day she wakes up and she can't catch her breath. So from that big injury to those blood vessels that ruptured, that gave her their bruise, she actually threw a clot that went back to her lung, and she had a pulmonary embolism. She lived, but you know, that's kind of so rare. It's just one of those things you really only hear about once or twice, but it is technically possible. If somebody gets a bruise, right, and that's a blood vessel that's been broken, and there's a clot that's developed to seal off that blood vessel, that it is possible that the clot could break and travel further down inside the blood vessel. And if it makes it all the way back to the heart, it would lodge, again, it would go right atrium, right ventricle, and lodge into one branch of the, you know, wherever it lodges in the pulmonary artery system in the lungs. Okay, so elevation we don't worry about anymore. That was after we put direct pressure, we elevated the limb upward. They say it does nothing. In other words, you can't elevate it high enough that gravity helps and stuff like that. Now, hemostatic agents are very important. So hemostatic agents are basically commercially prepared gauze pads. It could be roller gauze, it could be flat pads, it could be, it looks like bean bags. They're all different ones out there depending on the one you buy. But they're impregnated, or they have sprayed onto them chemicals that help the body's you know, own bleeding control to work better. It was actually invented by the Israelis. You know, they I guess licensed the technology, you know, to the American Army, and now it's just available, you know, commercially. You can buy it, you know, even in a CVS or something like that. They're very expensive. Like a package like that is probably like $20-something, you know, to buy and stuff like that. But what happens is that when you use it, it actually does a better job than just a plain, you know, gauze pad that costs a penny. It just does a much better job. So we don't use it for minor bleeding. We use it for severe bleeding. Now, this is what they call roller gauze, which means that it looks like toilet paper will unroll. A lot of people open this up and shove the whole thing in the wound and say, well, that's what it must be doing. But actually, the right way to use it, if it's a roller gauze type of thing, is to actually feed it in. In other words, roll it in like you're rolling in toilet paper into a wound, because the way this works is that every piece of it was sprayed with the substance. So if you put it in whole, you only have two sides that have the substances touching the bleeding. If you unroll it, you have now 3 feet of it, right? That's all impregnated with the substance that's down in the wound. The problem is in real life, if somebody has severe bleeding, it's a pain in the neck to, you know, hold this and unroll it and not have it roll and fall on the ground and everything like that. So sometimes people, you know, just shove it in there just because it's the quickest way of doing it, but it's actually designed to be unrolled. So how do hemostatic agents work? So some of them work by absorbing the plasma, okay, sort of fluid portion of the blood, and that helps to make a clot. Some of them work by actually working on the platelets and making them work better. So it's always, you know, a different way. But there's a couple things that you have to know about hemostatic agents to make sure you understand how they work, which is that they really work best if they come in contact with the vessel that's bleeding. So picture I had a deep cut on my arm, okay? It's laying here and there's blood pooled in this deep laceration, right? If you were to just take the quick clot, the hemostatic agent, and start putting it in the wound, it would not work. What you actually have to do is take a towel or whatever you have and wipe out the blood. Now that may actually start some of the bleeding again, okay? But where you see the bleeding coming from, you want to press the hemostatic agent down on there. And you may need to use multiple, you know, multiple packages, okay? And then on top of that, you want to add whatever else you have. Could it be regular gauze pads? Could it be a towel? And you want to fill that wound up, okay? But the hemostatic dressings have to come in contact with the bleeding wound. They're not supposed to be put into a puddle of blood or anything like that, but they have to come in contact. Where if we're just using a plain gauze pad, we don't actually want to take any of the gauze pads off, okay, because that may start the bleeding again. Here, we have to run the danger of starting the bleeding again because it only works if it comes in contact with the bleeding vessel, okay? So once you've filled up the laceration with hemostatic gauze and everything else, you can fill it up. Then you hold direct pressure, and it takes about 2 minutes for it to stop the bleeding. And once the bleeding is stopped, you wrap the whole thing tightly with the pressure dressing to keep pressure on it. Or you may not, you know, you may have to hold pressure yourself all the way to the hospital, but you you have to fill the wound, and that has to come in contact with the bleeding vessel for it to work, for it to work best. Okay. And if it doesn't work, then you go right to a tourniquet. And if you don't have this, you go right to a tourniquet. In other words, if you were not be able to control serious bleeding with just manual stable, direct pressure without hemostatic gauze, and you don't have hemostatic, you go right to a tourniquet. Okay. But most ambulances have this. It works pretty good. I don't know if Hatsola gives every unit one of these, or they just leave them on the ambulance. But it's because it is expensive. If you got 100 people running around, and you got to give everybody, $50 worth of it, you're talking, big money and stuff like that. But I don't know how they do it. And then the last step, if you cannot control bleeding any other way, would be to go to a tourniquet. Now remember, if you're by yourself, okay, and the only person the person has is bleeding, right? They have one bleed, then you're probably going to take the time and go through the steps we just described. But if you have somebody who's bleeding from 3 different places, or somebody who's not breathing and bleeding, and you're by yourself, you're not going to go to hemostatic gauze. You're going to go right to a tourniquet, because you have to stop the bleeding as quick as possible, okay? And then move on to, managing their airway. So, tourniquets are totally acceptable. Tourniquets do not result in a loss of a limb and all that kind of stuff, right? If the limb is going to be lost, it's because of the trauma that caused the injury that's making you put the tourniquet on. It's not because of the tourniquet. Okay, so tourniquets are used to stop arterial bleeding, okay, that cannot be controlled any other way. Now, can you use it for venous bleeding? Again, if you can't stop the bleeding, you can put a tourniquet on. So it's really any bleeding that you can't stop, but typically it's arterial bleeding, okay? Obviously, you can only use it on extremities, right? It can't work anyplace else. There's not a tourniquet you put around somebody's chest. There's not a tourniquet you put around somebody's neck, right? So it only works on the extremities, okay? And it goes what's called proximal to the wound. Proximal means between the wound and the heart, because you want to shut the pump, right? You want to shut the flow off to the wound. So it's always going to go proximal. So if I had a cut here, I would have to put it here, right? I don't want to put it down by my wrist, because that's not going to stop the arterial bleeding from getting to it if it's beyond the wound. And you'll know that it's tight enough when the bleeding stops, right? So the sign that it is tight enough is you tighten it until the bleeding stops, okay? Now, the last thing I wrote down there was after bleeding stops for 10 or 15 minutes, they may be loosened. So there was a period of time where we said we never loosen tourniquets. Then they said you could loosen them with medical control's permission. So I put question mark, question mark. Well, the reason I did that is that in Rockland County, okay, we're going to be at the hospital. So the only time you may think about having to loosen a tourniquet would be as if the person was entrapped in something, right? Like we're in a bad car accident, okay, and you can't cut them out. The fire department's trying to cut them out, and it's an hour, they're still in there and stuff like that. So a lot of times if that happens, what we will do is actually request a doctor to the scene. Like we have somebody entrapped, and there's a chance that we have to maybe cut them free or actually amputate. Like, there was once a case where somebody's leg was so badly mangled in the metal that we thought that we were going to have a surgeon come to the scene and cut the leg off so we get the patient out of the car. We were able to free the leg before the surgeon got there, so it didn't have to happen. So it'd be pretty rare in Rockland County where you would have to worry about loosening a tourniquet, but that does exist if it needs to be, but it has to be with medical control's permission. Okay, but typically 99.9% of the time you put a tourniquet on, it's going to remain on to the hospital. Now, one thing they don't talk about in the book, okay, is that tourniquets are extremely, extremely painful. Like on a scale of 1 to 10, they're a 10. They're very, very, very painful. So if you have a patient that's still with it, still conscious, they may actually try to remove the tourniquet, okay, because it hurts so much. So you have to watch, okay, that they don't actually remove the tourniquet and bleed to death. It happened to me once. It happened to me with a patient that had 3 tourniquets on. And, while we were managing a really bad bleed down towards his foot was pretty much broken off. He managed to loosen one on his arm. And we didn't really notice it for a couple of minutes until there was so much blood on the floor. We were saying that there must be some other bleeding happening. And it was actually just that he loosened the tourniquet. That was I don't know if you heard, but I think it was like 2 summers ago. There were 2 drunk guys riding a lawnmower on Route 17 in Sloatsburg. And some lady, it was dark, it was raining, and she hit them. That was one of those guys. The guy that died was my guy, and he actually took his tourniquet off. That's how he bled to death. Stuff like that. So somebody wrote in the accident where the leg was pinned in, was the leg saved? No, it wound up being, just his foot wound up being amputated. Later, it was so mangled they could not keep it. Okay, so there's a lot of different types of tourniquets. We basically use a tourniquet called a CAT tourniquet, CAT. That's not the one that's up here, but they're basically a constricting band that goes around. You have to practice with the one that you are actually going to use in your place. But remember, anything that could go around the arm could act as a tourniquet. It could be a piece of clothing. It could be a shoelace. Ideally, we want it to be about 1 inch wide so it doesn't cut into the skin. But if you have nothing and the patient's bleeding to death, you would have to use what you use. Remember, a blood pressure cuff technically could be a tourniquet, right? Because if you inflate a blood pressure cuff high enough, no blood gets past it. The problem with a blood pressure cuff is it doesn't keep the pressure for very long. So if you were going to use a blood pressure cuff, you would have to have somebody continually pumping some air into it, especially if it's older. They tend to lose air pretty quickly. So again, there's a lot of different types of tourniquets. You have to know how to use them. So there's always instructions with them. Okay, again, once applied, do not remove or loosen. And then a new protocol, it's a little question mark. Now, they say that if you put a tourniquet on, you're supposed to write on the patient's forehead, TK, which stands for tourniquet, and the time that you put it on them, okay? So in real life, okay, one patient, one EMT, one patient, one ambulance, EMT is taking that one patient to the hospital. No need to do it, right? You're going to be with the patient, so you know the time you put it on, and you can tell the hospital that. So you don't need to write it on their forehead. What they really mean is, let's say it's what's called a mass casualty incident, MCI. Mass casualty incident means there's more injured people than there are people to help them. So what's going to happen is we go into what they call triage mode. Triage is a French word that means to sort through the patients. And nobody actually stays with a patient. The first crews on the scene start walking around and basically doing categorizing the patients. If they're not breathing or they don't have a pulse, they're categorized black or dead and nothing's done for them. Okay. Usually would say the patient in cardiac arrest, we stop and do everything for them. Because there's so many patients injured, a patient is already dead, we just leave dead. And we go on to say the person who has the arterial bleeding. And really all we do is stop it. So that means we would put a tourniquet on. Okay, and then we would go on to the next one. Now, if they have an arterial bleeding and they're not breathing, we'd put a tourniquet on, we'd open their airway. If they don't start spontaneously breathing, they'd be dead. We wouldn't do anything for them because they have multiple problems. So what you're basically trying to do is save as many patients as you can, realizing that the patients that have serious injuries probably are not savable. Okay. And again, this is very rare. It's never happened in Rockland County. Yes, we've had car accidents where there's 6, 7 patients, but we're talking really kind of situations where you're talking there's 100 patients, right? If we have a situation, 6, 7 patients, it may be an MCI for 5 minutes, but eventually you're going to get enough people to the scene to be able to manage all of them. So if you're not going to accompany the patient to the hospital, then you need to write on them the time you put the tourniquet. The place typically it's written is on their forehead. We also have what's called triage tags. Remember, triaging is the process of going through and sorting the patients. So a triage tag is a kind of a piece of like heavy paper, heavy stock paper, like cardboard almost, that has places to write what's wrong with the patient on it. And one of the things is to write the time of the tourniquet was applied. So, we'll talk about that more when we get towards the end of class and we do MCI, okay? So again, you always have to assess, is the way you're controlling bleeding working, okay? Or do you need to be more aggressive? So in other words, if you're doing direct pressure and blood is still spurting out underneath you, you may say, okay, this is not working, I have to go to hemostatic gauze. Or you may say, I'm gonna go right to a tourniquet. Okay, so if you decide to go to hemostatic gauze and after 2 minutes it didn't stop the bleeding, okay, then you're going to go to a tourniquet. The tourniquet is the absolute way of stopping bleeding. We don't have to let somebody lose more blood, okay, to wait to put a tourniquet on. It's a decision you would make. You would have to decide, what's the best way for me to stop this bleeding. And tourniquets are an acceptable way of doing it, okay? Okay, so again, they recommend a very systemic approach, right? So again, direct pressure, if that's not controlled and you don't have hemostatic gauze, you go to a tourniquet. If you do have hemostatic gauze, okay, then you could try that first before you go to a tourniquet. But remember, we have a finite amount of blood, right? 5 to 6 liters of blood. Okay, so we can't lose that blood and expect to stay alive. So stopping the bleeding, it takes the priority. So if you cannot control it without a tourniquet, you go right to a tourniquet. So some other things that are acceptable, okay, not in lieu of a tourniquet, but maybe in addition to, is if somebody has a fracture on the extremity, okay, after you stop the bleeding, putting a splint on, okay, to help stabilize it so the bones don't cut any other arteries is acceptable. And if you have a very minor bleed, like somebody has a contusion, a bump on their head, cold makes blood vessels constrict so that there will be less bleeding, okay, if you, put a cold pack on their bump on their head because it'll cause the blood vessels to constrict. But again, that's very minor bleeding. So somebody put, is 9/11 an MCI? So 9/11 was not really an MCI. There were actually very few patients to manage. People thought there were going to be hundreds and hundreds and hundreds of patients, but there really weren't. There were very minimal, patients to manage, because unfortunately most of them died. But there was a lot of people covered in dust, a lot of people dirty, a lot of people like that. But as far as seriously ill patients, there were probably less than 100 seriously ill patients and stuff. Here in Rockland, they called us up and said that they were going to use New Jersey Transit train and bring the patients up by train to Suffern, and then we were going to transfer them to Good Samaritan and to Nyack. This was going to be not the seriously ill patients. These were going to be more of the minor patients, and they told us to start expecting them around lunchtime. And they actually cleared out the parking lot of the train station in Suffern. And everybody's waiting, and like 2 o'clock in the afternoon, a train pulls up. 4 or 5 people get off covered in dust, and their first question was, where's my car? And we had towed their cars. So here's where people actually managed to get out of the city. They actually were brought by boat from Manhattan over to New Jersey, and then so they survived this whole horrible event. They came by train, almost a private train, because it was really nobody with them. They came by train up to Suffern, and we had taken their cars and towed them because we thought there was going to be a need for a big field hospital and everything in the parking lot. So there really wasn't much to do on 911. So it says, can a tourniquet be placed on child? Absolutely. If they have severe arterial bleeding, a tourniquet can be placed on anyone if that's the only thing that's going to save their lives, right? So whatever it takes to stop the bleeding is what you have to do. Okay, head injuries and bleeding. Okay, so if somebody's bleeding from their ear, from their nose, from their mouth, okay, that we don't try to do anything to what they call pack it. So if somebody's bleeding from their ear, from their nose, we don't do anything to shove up there to try to stop the bleeding, because you're not actually getting to where the bleeding is occurring from, right? The bleeding is deeper inside. So you don't put anything, deep up into there to stop the blood from flowing. They used to talk about putting like a sterile gauze pad over their ear just to prevent a barrier to infection and stuff like that. But you don't do anything to stop the actual bleeding, because that will increase the pressure in their head and stuff like that. Now, nosebleeds, remember I told you in the beginning class, you have to know this term epistaxis. So epistaxis is the medical term for nosebleed, okay? The other word you have to know is convulsions, right? And we saw at the other night, convulsions is how on the state exam they say seizures. I don't know why, because seizures is really the medical term, okay? So somebody could have a nosebleed. It could be because it's the winter time and they're in a hot air heating system type of house and they dry out, okay? It could be because they're on blood thinners. There's certain kids that get nosebleeds just because they get them, but it could also be because their blood pressure is very high, and that's causing the blood pressure, the blood vessels in their nose to rupture. Now, we know there's lots of blood vessels in the nose because we said that breathing through the nose warms and humidifies, moisturizes the air, and that's the blood vessels that do it. So people can bleed a lot from their nose, okay? And, it can get to the point, especially in people that are on blood thinners, they can get, fairly serious. The problem is that we have no real way of getting to the back of the nose, right? We can get to the anterior nose, this little piece you see here, right, from here to here. But remember, with the nasal airway that the nasal passageways, the nasal pharynx goes all the way back in here. So those patients may require immediate transport to the hospital, and they have a device they can pack gauze back up in here to actually stop the bleeding and stuff like that, okay? Now, if you had a patient who had a bad nosebleed, you have to worry about their airway. So if they're unconscious, they have to be put in that recovery position on their side, and you have to have suction available to try to remove the blood from them. So somebody wrote, loosening a tourniquet will ease the patient's discomfort. Yes, but it'll also start the bleeding again. So remember, stopping the bleeding is more important than the pain, okay? So you have to stop the bleeding, and it's going to hurt. So you're not going to loosen the tourniquet, okay, just because the patient says it hurts. The only time you would consider loosening the tourniquet if it's probably on greater than 15, 20 minutes and you don't think the bleeding is still going on, you could start gently loosening it and seeing if the bleeding reoccurs. But, we're not going to risk the patient losing more blood because of the pain and stuff like that. So somebody wrote, is it not clotting? So it may be clotting, but you don't know, right? You don't know anything. Remember, if this is a trauma patient, you're probably not going to have a whole detailed history on this patient. So, you got to realize that in trauma, everything hurts, right? A broken leg hurts, a broken arm hurts, putting a splint hurts. So you have to be able to deal with that fact that you may be helping them, and by helping them, you may actually hurt them a little bit. And that's just acceptable. I mean, anybody who gets a tourniquet put on, it's going to hurt. There's no doubt about it. But stopping the bleeding is more important, okay, than worrying about the pain. But again, if it's 20, 30 minutes into the transport, for some reason you're still with the patient and you think the bleeding has stopped, then you can take a chance on gently loosening the tourniquet. I would have all your other bleeding control devices available, your hemostatic gauze. I might actually, pack the wound, okay, with the hemostatic gauze and put a pressure dressing on before I started backing off the pressure on the tourniquet, just to help control the bleeding. Now, internal bleeding, there's not much we can do, right? We got to get them to the right hospital. So if it's a trauma patient, to a trauma center, we want to put them on oxygen. We want to keep them warm, okay? But there's not much we can do with internal bleeding because we can't get to it to stop the bleeding. Okay, so from an internal bleeding standpoint, internal bleeding can be blunt trauma, which means that nothing penetrated the skin, or it can be penetrating like a bullet or a knife, right? So either way, there's not much we could do. It's just easier to assess penetrating trauma because you can see a hole on their outside. But it can be falls, it can be motor vehicle crashes, right? It could be somebody struck by a car. It doesn't matter what the mechanism of injury is, but there's multiple ways that people can get hurt. But internally, it's rapid transport. I mean, all trauma is rapid transport, but oxygen, warmth is about all we could really do with that. So here they're just showing you rough estimate, okay, on fractures, how much blood they lose. So the fractures on the test that they're going to ask you, which fractures are really serious, are femur fractures. Remember, the femur is the big bone in your upper leg, and pelvic fractures, right? The pelvis is the, your the bones are the bones that make up the, how could I describe it? Where your, I guess where your legs get into is your pelvis area. So those bleeding in those areas can result in a lot of, fractures in that area can result in a lot of bleeding, okay? But every bone that's fractured, right? Because we said that bones produce the red blood cells. Every bone has blood vessels, right? That's how they stay alive. Bones need blood just like everything else does. Remember, bones are living things, right? It's not like they're this tree branch that's dead type of thing. They're actually living, that's why they hurt when they break, and that's why they can regrow when you have a fracture. So all fractures do result in some bleeding. Okay. Let me see what time it is. Okay, so we'll take a break in a second. Okay. So again, penetrating gunshot wounds, stab wounds, we had a guy the other day that at a construction site fell on a wooden stake that was in the ground, right? And it went into him. So anything can, penetrate the body if it's sharp enough and stuff like that. So how do you see external bleeding? Sometimes it's just based on mechanism, right? Just what they tell you happens. Sometimes you'll see something actually in their body. Sometimes you may see a bruise. This all comes down to, again, time and experience in assessing enough patients and stuff like that. Their belly may be hurt, right? Their belly may be rigid. When you touch it, it's like a board. Okay, it may swell. Distended means it swells because of bleeding in there. They may be vomiting up. Okay, blood, or if it looks like coffee grounds, that's usually old blood. Maybe coming out their butt, right? So it could look like dark tarry stools, like blackish stools, or it could be bright red depending if the blood is old or new, right? If the bleeding is old bleeding or new bleeding, they could have signs and symptoms of shock. Okay, so here's a situation. This is somebody's right arm, okay? So probably a motorcycle accident, okay? I would assume, not really knowing. He's got a cervical collar in place right up here. Oops, where'd it go? Can't find the mouse. Where is the mouse? Oh. Okay, here we go. Here we go. Okay, so he's got a bruise over here, okay? Cervical collar in place, blood pressure cuff, EKG monitor, right? So he's got a big bruise over here, probably fell. I would say it looks like a motorcycle or a bicycle or something like that. So he's got black and bluish discolorizations, right? So that's the bruise. When you actually see the black and blue, that's called ecchymosis. I'll show you that word in a second. And he also has abrasions where the skin is rubbed off, right? So he's kind of multiple external injuries, but internally, obviously, if he has a bruise, that means the blood vessels in his arm were ruptured, right? So, and we don't know. We don't see the rest of his body. We don't know what else is going on with him. So again, for trauma patients, bleeding patients, okay, you're going to obviously maintain their airway, breathing, circulation. You're going to put them on high concentration oxygen. All trauma patients get high concentration oxygen no matter what their pulse oximetry is, okay? Any external bleeding that you can control, which again would be extremity bleeding with the tourniquets, or if it's on their chest, abdomen, you could try direct pressure, okay? Keep them warm because we said that if they're cold, they bleed more. And then you have to not stay around on the scene. You have to transport immediately. And again, these patients have to go to a trauma center, okay? Okay, so let's take a break here and then we'll come back and we'll finish up with the different shocks. It is 9:34, so come back about 9:45, okay?
Pressing on the nose on top,
Hold on
the
one
bone.
second. Hold on one second. Okay, so we're going to, okay. So we're going to just do a quick review on shock and hyperperfusion, and then we'll call it a night. So just remember, on the state exam, there's probably going to be about 10 questions on shock and hyperperfusion, and there's probably an equal amount on CPR, you know. So we'll go through, you know, as we get closer to the state exam, again, reviewing more questions and also talking about what categories, you know, have, like, say for burns, there may be 2 questions on burns, but CPR, there may be 12 questions. So, you know, you need to know where to concentrate your last minute studying to the ones that have the most questions stuff. Okay, so shock, obviously we call hyperperfusion. We said perfusion is that the capillaries are getting blood that contains the things the cells need, oxygen and sugar on a very basic level, and able to give them up out of the capillaries into the cells so the cells can make energy, okay? And that the cells burning that stuff is called metabolism, right? So perfusion is that the cells get it. Metabolism is that they get what they need and able to use it to make energy. Okay, so when there's shock or hypoperfusion, it means that there's inadequate tissue perfusion at the capillary level, okay? But to realize that it could also be that, you know, the waste products that build up in the cells, the carbon dioxide, the lactic acid, you know, all the different things are not getting removed, right? So it's a combination of both things. We worry more about the concept of getting the blood to the cells and that the blood has the oxygen, right? That's what we really kind of worry about on an EMT level because we can't fix the more complicated things. Okay, so when we talk about shock, it has to be some kind of problem in the circulatory system, right? So the circulatory system, again, we just said makes up the heart, which is the pump, the blood vessels, and the blood, right? So if it's going to be shock from the heart, it's going to be that the heart is not pumping effectively, okay? If it's going to be problems with the blood vessels, it's going to be either that the blood vessels dilate, means that they get too big and the pressure drops, or that they get blocked, okay? So that's the obstructive. Dilation is the distributive shock. The blocking is the obstructive shock. Or it's a problem with the blood itself, right? Or the fluid in the body. So blood itself is called hemorrhagic shock. And the other fluids that are in the cells and around the cells is called the metabolic shock, right? The diarrhea, the vomiting, and stuff like that, okay? So, okay, this is a stupid slide, but whatever, you can look at it later. But let's talk about the stages of shock. When the body is trying to do something to keep the blood pressure up is called compensated shock, right? So we said that the body can get an idea of what the blood pressure is because it has special nerves on the blood vessels that detect the amount of pressure or stretch. They're called stretch receptors, baroreceptors on the blood vessels. We also talked about that the body has chemoreceptors in the blood vessels, special nerves that look at the level of gases, oxygen and carbon dioxide, and that tells us how often to breathe. Normally it looks at carbon dioxide, and if the carbon dioxide is high, it makes us breathe more. And if somebody has that chronic obstructive pulmonary disease, that emphysema and chronic bronchitis, because the levels of their carbon dioxide are always high because they have lung disease, it switches to looking at the level of oxygen, right? And if the oxygen is low, it makes us breathe more. If the oxygen is high, it makes us breathe less, right? So, but those are rare, you know, you don't see too many of those patients anymore because less and less people smoke and stuff like that. Let me just let some people in. Okay, so in compensated shock, what does the body do? Okay, so obviously it tries to not have blood go to the area where there's bleeding, if that's the cause of the problem. It tries to make sure there's a good amount of blood going to the vital organs, the brain, the kidneys, the lungs, and stuff like that. It tries to conserve fluid, so you're going to get thirsty feeling. You're going to not have the need to urinate. It's going to increase your heart rate, try to make you pump more blood to raise your blood pressure. It's going to make you breathe deeper and faster to bring more oxygen in. So it's going to do things to try to keep the blood pressure normal, right? So that in compensated shock on the test, the blood pressure should be normal. Decompensated shock means that it's not working, right? Whatever the body was trying to do to keep the blood pressure up is not working, okay? And the blood pressure starts to fall. Obviously, that's a dangerous stage of shock to get into, because if you're not perfusing your organs are not going to work and you are eventually going to die, right? So that's the problem. So we try to find people, right, while they're still in compensated shock, keep them in compensated shock and get them to the hospital before they
How long
get
can
into
a patient be?
decompensated shock. What's that?
How long can a patient be in a state of compensated shock? Days?
So no. So see, it depends on a lot of things, right? So first of all, I would say is what's the age of the patient? What's the health of the patient? That's the first thing. So a young, healthy person is going to tolerate, right, shock better than somebody who's older or somebody who's a small child. Okay. The second thing is, what's the cause? Like, what type of shock are we talking about? The other thing would be what kind of medications they're on, right? Are there medications that are going to help them or make them worse? So if they're on blood thinners and they're bleeding, it's going to make them worse. If they're on blood pressure medication that's supposed to keep their blood pressure low, it's going to make them worse, because in compensated shock, you want to keep the blood pressure up. What else could we say? You know, I mean, there's just so many other variables. It's kind of hard to predict how long somebody could be in, but long and short is a young, healthy person on no medicine is probably going to do better than an older person on a ton of different medicines. But it also depends on what's their injury, right? So it's there's no way of predicting. You have to take each patient individually to see.
That comes only after an injury?
No, you could have somebody who has, I don't know, gets, you know, a gastrointestinal virus, and, you know, they're 90 years old and now they have, you know, vomiting and diarrhea for 3 days. So they could go into metabolic shock, right? Because they're losing all their fluids, not losing blood, but they're losing all their other fluids. So it really depends. I mean, you've seen your kids where they get a stomach virus and, you know, they can't even sit up because they're so weak, and you're running to the store to get them Pedialyte. So it really depends on, you know, the situation. It depends on the otherwise health. I mean, a young, healthy kid, some vomiting, diarrhea, you know, they can get sick. They get to the point where they need an IV, but most of them can, you know, get better with oral hydration. So it really just depends on a little of it's luck. A little bit is what's wrong with them. A little is what their, you know, previous medical conditions are. Okay, so in compensated shock, we said the body's doing something. So it's increasing the breathing, it's increasing the heart rate. Okay, it's trying to keep the blood pressure normal. Now, what's interesting here, usually I don't get into it on an EMT level, but, you know, normal to low systolic, normal to elevated diastolic. So they're breaking out the blood pressure in compensated shock to 2 different ways. So they don't, like I said, don't usually talk about this in EMT level, but what actually happens in your blood pressure when you go into shock is you have what's called a narrowing of the pulse pressure. And you don't, this is just listen for 2 minutes, and, you know, I'm not saying forget it, but you're not going to see this on the exam because it's really kind of above the EMT level. But the pulse pressure is the difference between the systolic and diastolic. So in other words, if your blood pressure is 120/80, you have a pulse pressure of 40, because if you take 80 away from 120, it's 40, right? 40, if you add 40 to 80, it goes to 120. So the pulse pressure is the difference between the top number and the bottom number. So you just subtract the bottom number from the top number. So now picture you're going into shock, you're bleeding, okay, or whatever happened, you're going into shock. What typically happens is that since the systolic blood pressure is the force in the blood vessels when the heart is contracting, that number tends to go downward, okay, as you start losing blood, right? Makes sense because you're having less pressure. But the diastolic is actually the pressure in the vessels at relaxation. And what happens when you start going into shock, as we said, is one of the things that the body tries to do to keep the pressure up is it constricts the blood vessels, makes them tighter to raise the pressure inside of them. So the diastolic is when it starts to rise, like they're saying here, where they're saying it maybe normal to elevated, means it's rising. That's showing you the vasoconstriction. So it's a very fine sign. The problem is that you have to be with the patient. First of all, you have to know what their blood pressure is probably before the injury to be able to know, compare it to the blood pressure at the time you're taking it. And then going forward, you know, looking at the trend, you'd have to be with them for a period of hours to see that starting to happen. So that's why it really never pertains to us too much in EMS. But physiologically in the body, what's the body trying to do? You see it that usually what would happen is you'll get what's called a narrowing of the pulse pressure. So usually the pulse pressure is 30 to 40 points, right? So, you know, so it's like 120/80 is 40 points, right? So it's usually about 40 points difference between your systolic and diastolic. So if you see that number now getting narrower, where instead of having 120/80, you're getting, say, 110/90, right? So now the top number is lowering, the bottom number is rising, and the pulse pressure is getting less. That's called a narrowing. That's usually a sign that the body's trying to, you know, compensate by constricting the blood vessels. Okay. Now, also in compensated shock, they say the skin gets pale, cool, and clammy. That's called diaphoresis or diaphoretic skin. And again, what's happening is that we said that it can move blood away from non-vital areas to vital areas. So your body can actually direct blood away from the areas that are not important. So the two areas that are routinely not important are your stomach, your gastrointestinal tract, right? Your intestine, your stomach, and also your skin. And the reason it's not important is that your skin can live without blood for a while. I mean, again, you're getting some blood. It's not cutting it off completely, but it could live with less blood for a while. And in your stomach, it only needs a lot of blood going to it when you have food in it. And it's the assumption is that if you're in an emergency state like shock, you're not really having a lot of food down there, right? You're not eating, so you don't have to worry about it. Okay, so that's why sometimes, like, you know, post Shabbos Suda, you feel exhausted. It's because what your body did is it's sending all the blood it can to your stomach to help you process all the food you ate during the Suda. And that's why you feel tired. Okay. Now, what's that?
Somebody goes into shock right after eating, then where's the blood going? It's not going to be.
You would not. It would still shunt the blood off to your stomach. It wouldn't send it to your stomach. It would know. It wouldn't care the food's down there. So it wouldn't really worry about that. So why does your skin get pale? Okay, so if you don't get warm red blood to your skin, it's going to get pale, right? And again, that's mostly seen in Caucasians, which are light-skinned people. Okay, it's going to get cool because you're not sending any warm blood, right, to the skin, so it gets cool. And the clammy means it's sweaty, it's cold, a cold sweat. Clammy means a cold sweat. Usually sweat is warm, it's you trying to get rid of heat. And again, the reason you sweat when you go into shock is that we said that you have little holes on your skin called pores, P-O-R-E-S, and those are where your sweat glands. Those are the holes that allow you to sweat so that if you need to cool yourself. And every one of those holes has a muscle that keeps them closed unless you need to sweat to cool yourself. But if the body is not bringing a lot of blood to the skin, those muscles have to relax because to be able to hold tight, they need blood going to them, right? They need energy to go to them. So when there's not enough blood going to them, they relax. So now the sweat comes to the surface and it's a cold sweat because you're not getting any warm blood to the area. So people normally do not have pale, cool, clammy skin unless they have some type of emergency going on, okay? The pupils become sluggish. Now, what are they talking about sluggish? The pupils are the lens of the eye, right? They're the amount, allows the amount of light to come to the shutter, I guess not really the lens, but the shutter to the eye. So they control the amount of light that's getting to the brain, right? So when you go into shock, there's a muscle that actually controls the size of your pupil. And if you're not getting enough blood to your eye, the muscle doesn't work and the pupil opens up. So a dilated, okay, pupil is usually a sign of shock. And when they say sluggish, they mean that normally when you shine a light, right, on a pupil, it constricts. But here it's going to seem a little slow to go, right? And then typically their mental status is not altered to the point where they don't make sense, but they usually say they're very nervous. They call it apprehensive, like they're very anxious, nervous. They know something's going on. You know, please tell me what's going on. Get me to the hospital, help me, and stuff like that. Okay. And then when they start moving to decompensated shock, what happens? The breathing starts to slow down because the muscles are not getting enough blood to make you breathe, the diaphragm and intercostals. Your pulse becomes weaker because you're using blood. Your blood pressure starts to drop. Okay, your skin again stays pale, cool, and clammy. Your pupils now start becoming very slow to work and they get dilated, and your mental status now changes to where you become difficult, if not unconscious, right? Difficult to awake, if not unconscious. It's just showing you the lack of perfusion to all the different organs, you know, in the body. So if you had somebody who was shot and they're unconscious, you could assume, okay, that they're in that decompensated state probably. Okay, so we talked about, we have different types of shock. So the first thing is that we divide shock into 4 categories. And then inside of those categories, we have the types. So you have hypovolemic, you have cardiogenic, you have distributive, and then on the next page, you're gonna have obstructive, right? So there's 4 types of shock. Hypovolemic shock. Hemorrhagic is a type of hypovolemic. Hypovolume, low volume, right? So here it's blood loss, here it's fluid other than blood. So hemorrhagic is blood loss, metabolic is fluid other than blood. Remember, 60% of our weight is fluid, and out of that 60%, very little of it is blood. So most of this fluid is the fluid we don't see that's inside our cells or that our cells are floating in, okay? So this would be more the vomiting, the diarrhea, the diabetic ketoacidosis that you don't know about yet in a diabetic where their blood sugar gets high and they start to urinate out a lot to get rid of the sugar. They actually can get shocky from it. Cardiogenic could be a problem with the heart, the pump. We said it could be that they had a heart attack and their muscle is damaged. It could be that have an infection in their heart. It could be there's a problem with their valve, or it could be that the sac that's surrounding the heart, fluid starts to build up inside that sac and start squeezing the heart because of infection or maybe trauma, okay? Distributive shock, we said it's when the small blood vessels suddenly get bigger, the diameter of them gets bigger, so the pressure has to drop, because remember, if you have a closed system, like a heart and blood vessels is a closed system, and you have 6 liters of blood in that closed system, but the blood vessels are at a normal diameter, everything's fine. But now you increase the size of the blood vessels because you have one of these problems. You didn't get any more blood, so the pressure inside of them has to drop, right? So that's what happens with distributive shock. Sepsis, we said, is a severe blood infection, right? A system-wide infection. Anaphylaxis, we said, is a life-threatening allergic reaction where not only do you have breathing problems, but your blood vessels can dilate. Neurogenic, we said, somebody has typically a spinal cord injury in the neck, and the impulses that would tell your blood vessels to constrict are interrupted, so they dilate, they relax and dilate, okay? And vasovagal is that psychogenic or psychological situation where, you know, somebody hears bad news or sees something and their brain sends a signal to slow down their heart rate and dilate their blood vessels. It could also be caused by increasing the pressure in your chest, and the most common way people do that is by older people straining on the toilet to go to the bathroom, like they're constipated, okay?
When someone goes into a hot bath, does that fall under vasovagal?
So
If they-
yeah, yes and no. So what happens with warm water? So like say a mikveh, right, or a really hot, you know, hot bath and stuff like that. When you're, first of all, when you're lying and relaxing, okay, your blood pressure drops, okay. The second thing is the heat causes your blood vessels to dilate. So now if you suddenly stand up, jump out of the shower, and you're not holding on to something, especially if people are on blood pressure medicines and stuff like that, which is supposed to keep their blood pressure lower, they could have a couple seconds where they're not getting enough blood up to their brain. And of course, the brain will just shut off if it's not getting enough blood, and you faint. And then you could fall and hurt yourself, right? So that's, so, you know, if you're in a hot bath, the thing is, first sit up, okay, give it a second, then kind of get on your knees, right, and give it a second, and then start slowly standing up, but always try to see someplace you could grab if you start feeling dizzy. And again, for most of us, it's not a problem. It's more the elderly patients. You know, we could even have that when we're sleeping, like you're sound asleep, your blood pressure is nice and low because you're relaxing. Your heart is not pumping hard because you're supine. It's very easy for blood to get up to your head. And now you jump up suddenly because your alarm goes off or your kid calls for you or something like that. There are people who faint, right? Because they jump up and now getting blood to their head is harder, and they have just a couple seconds where their brain is not getting perfused well enough and they faint. And the injury is not because their blood is not getting to their brain. Their injury is because they fall and hurt themselves. And then, you know, as far as rare shocks, you know, the obstructive shocks are pretty rare, where, you know, there's some kind of blockage in a large blood vessel. So attention pneumothorax, again, we'll explain probably another couple of days when we do chest injuries, but that's where a lung has a hole in it and the air is leaking out into the chest cavity, into the thoracic cavity, and pressurizing it, and it's not letting blood flow because there's so much pressure. And a pulmonary embolism is a blood clot that develops in a pulmonary artery. So these are where the blood can't flow through the blood vessels well, okay? Okay, so again, we just reviewed this, but hypovolemic, okay, is typically blood loss. We said we could do a good job controlling external blood loss between direct pressure, hemostatic gauze, and tourniquets. Internal bleeding, all we could do is put them on oxygen, keep them warm, and get them to the hospital. Okay, sometimes they have a test question that says, you know, which of the following types of internal injuries can an EMT best manage? And what they want you to answer is fractures, is broken bones, right? Because it is an internal injury, but they feel that by splinting it, you stop it from moving so you can manage it. Where if it's like a gunshot wound to the belly or the chest, there's really nothing we could do. So we'll see that when we go over more questions as we go through the class. And then the metabolic shock is the fluid other than, okay, blood. So they have vomiting, diarrhea, dehydration, heat when you're sweating. And some people put burns under metabolic. Some people put burns under hemorrhagic. With burns, when you have a burn and you damage the skin, you know, sometimes you see a blister, which is plasma trapped under the skin, or sometimes the burn actually just breaks the skin surface and the plasma is just leaking out of the skin. So again, because plasma is part of blood, some people put it under hemorrhagic. Typically on the state exam in New York State, they put it under metabolic, even though it's part of blood. Okay, so in burns, there's a lot of different things we'll talk about that can go wrong with a patient. But one of the things is they can get shocky if they have large areas burned because they lose so much plasma through the burn. Okay, cardiogenic shock, we said, is a problem with the heart pumping. So you can see that when someone has a heart attack. And remember, the medical term of a heart attack is myo, is muscle, heart muscle. Myocardial infarction is death of a heart muscle. And we're going to spend, a whole day talking about heart problems. Okay, it could be result in some kind of problem with the pumping of the heart. Okay, or that the heart is damaged and somehow that it can't pump with enough force. It could be a problem where the conduction system is not sending out the right amount of impulses. It could be a problem with valves, but we can't do anything with this, right? This is in all honesty, we probably wouldn't even know that it's cardiogenic shock on an EMT level. It's something that requires, testing in the hospital. But again, we have somebody who's probably unconscious or soon to be unconscious, very cold skin, no blood pressure. We're going to put them on oxygen, transport them to the hospital. It's not really, even on an ALS level, there's nothing you could do for this. Distributive shock is the small blood vessels that suddenly vasodilate. There's no blood loss. Okay, but again, the container, the tubes are so much bigger that the volume of the blood is not enough to fill it up, so the pressure drops. Again, we said neurogenic shock is a problem where there's a spinal cord injury and it interrupts the ability for the body to constrict and close down on the blood vessels, so they just dilate. Also, there's a problem in neurogenic shock with breathing because the muscles that control breathing, the diaphragm and intercostals, are not getting the signal to breathe. So we may need to, besides the problem from shock, we may need to ventilate them. There's also a problem with temperature control because if all their blood vessels are dilating, all their warm blood is coming out to their surface. And if they're in a cold environment or laying on a cold ground or in a swimming pool, they're going to cool down, right? So a very tough shock. Survival rate of neurogenic shock long-term is very poor, right? People are paralyzed, it's very poor. Septic shock, is the kind of the big thing we talk about now with all the different infections, right? So people get a body-wide infection. That's more common in people who are older, people who have taken chemotherapy drugs that suppress their immune system and stuff like that, but it can happen to anyone. Again, the blood vessels just dilate. Anaphylaxis is somebody whose immune system, the immune system is the part of the body that's supposed to help you fight foreign things and bacteria and viruses, but sometimes it overreacts. So you drink milk and you have a severe life-threatening reaction when there's really nothing dangerous about milk. It's just that your immune system is confused. And we will spend a night on anaphylaxis, but basically in anaphylaxis, you could have skin symptoms where the skin gets itchy and you get hives or bumps. Again, it's the plasma leaking out of the blood vessels under your skin, just like in the burns, but for a different reason. That's not going to kill you, but then it can progress on to where your larynx starts to tighten, so you'll have stridor, can't get air in. Your lower airways, your bronchioles start to tighten, you get wheezing. And then the last stage is usually as your blood vessels dilate, okay? And your pressure drops. That's why it's called anaphylactic shock. That's one we could actually treat because we have epinephrine. So we have EpiPens. Epinephrine causes the breathing passageways to open up so they could breathe easier and causes the blood vessels to constrict. So we actually raise their blood pressure. So epinephrine is the life-saving medication that we administer people in anaphylactic shock. Vasovagal, again, if they didn't hurt themselves falling, typically it's not a big emergency because whatever caused them to faint, whether it be bad news, blood, straining on the toilet, once they faint, they stop doing it. So the body then goes back to normal over a period of, 15 to 30 minutes. So it really comes down to, is it a true vasovagal problem where it's like something triggered it to happen, or is it a problem with their heart actually not working right? In other words, it's going to be a long-term problem. So if you see them starting to get better, it's probably just straight vasovagal. And then it comes down to, did they hurt themselves, okay, when they fell? If not, you can elevate their legs a couple inches, 6 inches to get more blood flowing down towards their brain, put them on some oxygen, okay, and they should slowly start coming around. But again, you don't want to wait on the scene, so you could always just put them on a stretcher and start transporting, and if they wake up in the ambulance, that's fine. Okay, so again, the vasodilation one is basically the problem with the blood vessels not being tight enough, right? So, okay, and that causes the blood vessels to dilate. So this is showing you the inner part of a blood vessel is called the lumen. So this one is nice and tight, so the blood is filling it all up. This one has vasodilated, has gotten bigger, so you see the blood is only filling up half the size of the blood vessel, which means the pressure on the walls have to be less. And if the pressure is less, blood doesn't flow as effectively. The second thing that could happen specifically in sepsis, okay, is that the capillaries actually start to leak some of the plasma out of the walls, okay? So that's a secondary problem, but it's not the biggest problem that somebody faces in sepsis. The vasodilation is really the biggest problem. Okay, so this is just showing you, again, it looks like it's kind of like a car crash, but it's looking like the capillaries are kind of leaking plasma out of them. So if you're losing the fluid portion of blood, you're obviously losing, part of the pressure, but that's not the biggest thing we really need to worry about. Obstructive shock, we said tension pneumothorax and pulmonary embolisms are the two biggest areas. And again, we'll explain those more as we go on. Nothing we could do in either one of those situations, but get them to the hospital on the EMT level. So it's just showing you on the tension pneumothorax, because air is increasing in here because it's leaking out of the lung, it starts to build up so much pressure, it starts to crush, okay, everything in the middle. And what happens is that your low pressure blood vessels, your inferior and superior vena cava, okay, can't get blood back to the heart. So if you can't get blood back to the pump, then the pump doesn't have anything to pump out and your pressure drops, right? Okay, pediatric wise, okay, kids tend to compensate better because why? They have probably no disease in their body. They're not taking any medications and they have a young, healthy, well, their organs are not diseased yet, right? So, I mean, it's easier for them to compensate. The problem with that is that, when they do decompensate, they tend to fall harder. And the reason why is that from a metabolism standpoint, like metabolism is the burning of the food and everything, the kids, their engine, right? They're, if you think of them like a car, their engine is much smaller. So it has to work much harder, right, to keep them going. And plus everything in a child is growing still. It needs more. It needs more oxygen. It needs more sugar. It needs everything, percentage-wise higher than an adult does. So when it's deprived of it, it's a bigger problem. So yes, they do compensate better, but when they crash pretty hard, right? So that's the issue. I mean, thankfully, it's very rare to have any of these problems in kids. I mean, it is pretty rare. But just to recognize that you may not see the signs and symptoms as quick because they compensate better and stuff like that. Okay. Okay, so progression of signs and symptoms of shock. So we said that in early shock or compensated shock, they're going to have an altered mental status. It means that they're not going to be 100%. But it's not that they're typically unconscious, right? So what it is that they're nervous, they're restless, they have anxiety, they're nervous. They know something is happening. So just kind of help me, make me feel better. What's going on? Get me to the hospital. So they're just, they're very nervous. They sense something is wrong in their body. Again, the skin gets pale, cool, and clammy. We call that diaphoresis, or we say diaphoretic skin. And we explained that because that's not enough blood flow getting to the skin. They can feel nauseous and vomiting because, again, the body is shunting blood or directing blood away from their abdomen, their abdominal organs, because it doesn't assume they need it there. So you can start feeling nauseous. If you ever had to speak in public or you ever got nervous and you feel like your stomach has butterflies in it and it's bouncing all over the place, that's, again, because your body sensed you were nervous. It thought there was an emergency going on, and it starts to send blood, okay, away from your stomach because it assumes you're not going to eat if there's an emergency going on. That's also why sometimes when people are nervous, their skin gets cool and pale and sweaty, right? Because it's the same thing that's happening, except you're just tricking your body. You have to get up and give a speech in front of 100 people and you don't normally speak, right? So you're going to be scared. And because you're scared, your body's going to assume that there's some emergency going on. And it's going to make the same things happen as if you're trying to compensate. Okay. Now, vital signs, we said early on that the blood pressure is probably going to be normal. If we really remember, we said we might see the systolic starting to drop a little bit and the diastolic starting to rise, which is the narrowing of the pulse pressure. But you're definitely going to see tachycardia. You're going to see rapid breathing. You're going to see deeper breathing, right? Trying to bring in more oxygen and stuff like that. Okay. And then again, the late signs, okay, is that people start, late signs of early shock, right? Or people start getting thirsty because you're losing fluid. Okay, their pupils start to get dilated where normally they're a little constricted. Okay, and they're sluggish when you shine a light in their eyes. They don't respond as quick. Okay, and then if the perfusion really starts to get low, you may see some cyanosis. You may see decreased capillary refill at the nail beds and stuff like that. Okay, so the term transportation is an intervention. Intervention is a treatment that we do for a patient. And what they're trying to say is just remember that if somebody's in shock, we're not going to fix it in the field. Okay, in other words, yes, we can stop external bleeding, but we're not really fixing if they're in shock. We're just preventing them from getting any further into shock. So that in that situation, getting them to the right hospital as quick as possible is actually a life-saving intervention or a life-saving treatment. Okay, so basically we have about 10 minutes max on a serious patient that we should be on the scene, as long as they're what they call accessible. Accessible means that there's nothing stopping us from getting them in the ambulance. In other words, they're not trapped in a car. They're not 500 pounds that we can't carry them out of the house. So that if they're accessible, you should basically note the time you pulled up, and if you see you're approaching 10 minutes, you should just get going, right? You can do everything else you need to do in the ambulance. Now, if they're have severe bleeding, you're going to try to put a tourniquet on them before you're going to move them out, right? If they're not breathing, you're going to start ventilating them before you move them out, but you're not going to stay on the scene excessively trying to figure out every single thing that's going on in a serious patient. It's be better to try to figure out in the ambulance, okay, going to the hospital. Also, again, in shock, heat, remember we said that if they're cold, they coagulate worse. So definitely in hemorrhagic shock, you want to keep them warm, but all shock, since there's poor perfusion, they would benefit from being kept warm. Okay, coagulopathies mean that if you're cold, they don't coagulate, they don't clot their blood, okay? So that's why it's best to keep them warm, because by helping them to clot their bleeding, if it is a bleeding type of shock, you prevent further blood loss, okay? So again, we always wanna make sure they have a patent airway, which means their airway is open, okay? And if there's any problems with breathing, we could either, if they're breathing deep enough and fast enough, we can give them supplemental oxygen from a non-rebreather or a nasal cannula. But if they're breathing too shallow or not enough times a minute, then we need to use the bag valve mask. Okay, any external bleeding we want to control. And this is showing you down here, I know it's a little hard, but this is their pelvis area, right? So here's their belly button, here's their legs. This is their pelvis area. If somebody was hit by a car, somebody was crushed in this area, if you remember that earlier slide, they said you can lose between 1,000 and 2,000 milliliters of blood in the pelvis. So you have 5,000, 6,000 milliliters of blood. So losing 1,000 or 2,000 milliliters is a lot of blood. So you can't actually reach inside the pelvis, right? This is all bone to stop the bleeding. But what they found is that if you put a device around them that puts what they call circumferential pressure, pressure around them as a circle, it actually reduces the bleeding. So everybody has different devices. There's even a way just to do it with some sheets and stuff like that. If we have time in class, we'll go over it. But, they sell these fancy devices that kind of act like a girdle around the pelvis to help stabilize it. The last time I used it was a young girl a teenage girl who was riding a horse, and she fell off the horse, and the horse then fell on top of her. So horses weigh thousands of pounds, and it crushed her pelvis. So the ambulance had one of these. We put it around her. Okay, again, any broken bones, okay, we want to splint because they also can, lose blood through them. We want to keep them warm to help with the clotting that's going on in the body and get going to the hospital as quick as possible. We don't use these anymore. These were called either MAST trousers, M-A-S-T, or PSAG, right? So military anti-shock garments, because the military first invented them. And then when it went to civilian setting, pneumatic means air anti-shock garment. So basically, it's like a fancy pair of pants that goes basically from right under their diaphragm, right under their xiphoid process, all the way to the bottom of their legs. And you fold these over in this Velcro, so it looks like you're actually putting a pair of pants on them. And then there's bladders like a blood pressure cuff to put air in them. What they basically thought, okay, was that by compressing down on the blood vessels, you would force blood back up towards the vital organs in the chest, and then obviously if it gets into the chest, up to the brain. So we used them for a bunch of years, and they actually found that they don't really help, but they're still technically, okay, in the protocol as a splinting device if somebody's broken up from the pelvis down, right? So if they have their pelvis broken, their femur broken, their tib fib broken, right? That by wrapping this around and putting a little air in it, you help stabilize it. I don't think there's any ambulances left in Rockland County that carry them anymore, but it is in the protocol, the New York State protocol, to use as a splinting device if you have, multiple lower extremity fractures. So I just always put a slide in here to talk about it. I don't think, this is something you would probably see on most ambulances. Okay, so somebody asked, is this what they use when transferring by air chopper? No, nobody really uses them anymore. It's just, it was like, anything. When it first came out, everybody thought it was great. Then when they looked at it and studied it and examined patients that it was used on, they found that it was not as great as they thought it was. Okay, so we talked about that. We talked about this. Okay, again, we said, what am I doing? Going backwards, sorry. Okay, so again, in our protocol, Well, actually this changed, so I'm just going to skip over that. That's not really in our protocol. Really in our protocol now, it's just for splinting and stuff like that. So that's really where it is. And if you could see, there's more contraindications, which means reasons we wouldn't use it, than there are indications to use it. So it's not really a common thing to use anymore and stuff like that. But this is kind of how the patient would look when they were in it, and their feet would actually turn, blue because you were actually depriving blood to go down there. Now, just another type of injury that you'll hear on the exam, and we're going to talk about this a little more, the next night that we meet. But an evisceration is where there's a cut through the abdominal cavity, okay? And what happens is that this looks like intestine, maybe a liver, I don't know, but that the abdominal organs start to protrude through the cut, okay? Because everything in your stomach is kind of tightly held in place. So the treatment is not to pack the organs back in, at least in a civilian setting here, but what it is to cover them with a moist sterile dressing and then put our airtight dressing over them. So what it means is that we would take our largest dressing we have, okay, soak it in some sterile water, squeeze out the water and cover it just to stop it from drying out. And then to take a large piece of plastic and tape it over. Now, the reason we're putting the large piece of plastic over is if you had a cut like this on a night like this tonight, this patient was outside, you'd actually see the heat leaving their body. You ever see sometimes when you breathe, you can see like the hot air coming out of you? The same thing would happen. So the moist sterile dressing is to prevent it from drying out. The airtight dressing, occlusive dressing, airtight dressing is to stop heat loss. Okay, so, but again, that's most important on a cold night outside, right? If this happened inside, it wouldn't be a big problem. Impaled objects, we don't remove, okay, for the most part, unless it's interfering with airway problems. So really the main place we could remove impaled objects is the cheek, the side of the mouth over here. But we stabilize them in place. Now, if they're very, very long, we may have to actually cut to shorten them, okay, but we typically stabilize them in place, okay? Okay, so let's do a quick review and then we'll call it a night, okay? So almost all external bleeding can be controlled by pressure, right? So whether it be an extremity, whether it be on your torso, usually by putting direct pressure, it'll work. Where it doesn't work, if it's deep inside the body, right? In other words, if it's a blood vessel under your rib cage, you can't press on it. But if it's the skin above your rib cage, you can, okay? Hemostatic agents help, right? And again, we said for hemostatic agents to work best, they should come in contact with the bleeding vessel and be held in place for at least 2 minutes and then have a pressure dressing applied over them. If we have bleeding on an extremity that we can't control by any other means, we can go to a tourniquet. And we said that we tighten the tourniquet until the bleeding stops, and the tourniquet has to go proximal to the wound, which means it has to be between the wound and the heart, right? So it's not going to be distal past the wound because arterial blood, if my cut is here, arterial blood is going this way. So I have to put it between the wound, okay, and the heart. If I could spare a joint, okay, which means that if I could put it below the elbow, if it was on my arm versus above the elbow, and they have to have an amputation, it'd be better to attach the fake part here than it would be to have to put a fake joint in for the patient. So if you could spare the joint, that would be great. Okay, internal bleeding is not a lot we could do, but get them to the right facility. In the meantime, keep them on some oxygen, keep them warm. And if they talk about fractures, then splinting would play a role on internal injuries to stop any more bleeding from occurring. Okay. So we said the earliest signs of shock when they're in compensated shock is that the mental status is that they get restless and anxious, nervous. Their skin gets cool, pale, and diaphoretic that we call diaphoresis. Their pulse increases. Their pulse rate increases, okay, their respiratory rate increases, maybe initially even the strength of their pulse increases a little bit because they're trying to constrict their blood vessels, and their breathing gets deeper to bring in more oxygen. But if the problem is not fixed, if the problem of the shock is not fixed, then they move to decompensated shock, where all those compensatory mechanisms to keep the blood pressure up fail and the blood pressure starts to drop, right? And as the blood pressure starts to drop, their mental status will decrease up to and including unconsciousness, okay? So sometimes shock is hard to determine, okay? So, with outward symptoms and stuff like that. So sometimes you may just actually, based on what the patient or the bystanders tell you is the cause of their injury, you may just assume there's something, going on with the patient without actually seeing any real signs on it. Okay, so how do we treat shock? We want to make sure they have a patent airway, keep their airway open. Okay, we want to give them high concentration oxygen regardless of their pulse oximetry, even if it's normal. We want to control any external bleeding, and we want to keep the patient warm, and we want to transport them to the appropriate hospital, right? They need to go, if they're a trauma patient, they need to go to a trauma center. So right now, I would say in Rockland County, Nyack's probably a little better to trauma than Good Sam, but Good Sam is in the process of, you know, getting their whole trauma system up and running also. Their true trauma center is Westchester. Okay, but sometimes the patient's not going to make it all the way to Westchester, so we stop at Nyack first to get them stabilized, and then we transfer them over to Westchester. Okay, so we said the circulatory system, the heart, the blood vessels, and the blood are what's designed to transport the good stuff to the tissues so that the tissues can do what they need to do. So the transporting of the good stuff to the tissues is called perfusion, right? Getting blood that contains the oxygen and the sugar to the cells of the body. Okay. The type of hemorrhage somebody will have is directly related to the blood vessel. In other words, is an artery, vein, or capillary. Okay, and then we said that arteries tend to be bright red and spurting type of bleeding. Veins tend to be a little bit of a darker red and flowing, and capillaries are also, you know, kind of bright red, but not quite as red as an artery. And they just tend to, they use the term ooze, which means they kind of just gently flow to the surface. Okay, we talked about how to do hemorrhage control. So we said we start with direct pressure. Hopefully we have hemostatic agents to include with that direct pressure. And if that fails, we go to a tourniquet. Okay, and again, internal bleeding is very hard to figure out and very hard to treat. So it's going to be keeping them warm, putting them on oxygen, and transporting. If the cause of the internal bleeding is fractures, we could try splinting also. Okay, we talked about the different ways that shock happens. So we had cardiogenic, we had hemorrhagic or metabolic. Okay, we had the distributive shocks, the sepsis, the anaphylaxis, the neurogenic and vasovagal, and we had the obstructive shocks, right? So those are all the different categories. Again, shock means that the body is not have good perfusion at the cellular level, at the capillary / cellular level, right? And we call it hypoperfusion. Okay, the most important thing we could do for shock is to recognize it and transport the patient, and en route to give them oxygen and keep them warm. The only real shock that we could 100% manage would be anaphylaxis. And again, doesn't mean that every patient who has anaphylaxis is going to survive because they have a shot of epi, but it's the one that we truly have the same treatment that would be provided by the paramedics, by the hospital, and everything like that. I mean, there's additional treatments, but the first line treatment would be the epinephrine. Also in vasovagal, right, we can help them by putting them on some oxygen, elevating their legs, and examining them for any trauma or anything like that. Okay. Okay, so we are somewhat caught up. Okay, if we do the next chapter, Motzei Shabbos, then we will be pretty much caught up for the time being. So like I said, for those of you to sign in later, 9 o'clock Motzei Shabbos, we're going to do whatever the next chapter is, I guess 14. If you cannot attend because you have previous obligations, I understand. Just make sure that you look at the YouTube video or the Dropbox for the video of it and review it. Okay, and does anybody have any questions on anything? Everybody's good? Okay, you guys were very good tonight. Not that many questions.
If we're doing a class Motzei Shabbos,
Uh-huh.
can we do it earlier? Because there's not too much time to sleep in the afternoon. And if we start 9 o'clock,
I'm fine. I'd start at 7 o'clock, but usually you guys have all your
I think
alphas.
8 o'clock. 8 o'clock should be fair. I don't know. It's not up to me, but
Okay, I tell you what. I would love to start at 8 o'clock. So unless somebody has a huge issue, let's start at 8. That would be great for me. What time did we start last week? At 9?
Yes.
At 9? Okay, so a lot of people are on the chat now. We got 9s and we got 8s. 8 o'clock is still Shabbos, somebody's saying. Okay, someplace in the world, yes, it is. But not in New York State, okay, unless you're really dragging it on. Okay, so whatever. Everybody, I've got more 8s than I got 9s in China, somebody said. I don't, I feel bad. I would love to make it 8, but I know some people drag. I mean, my father-in-law is the same way. So whatever. I think that if we do 9 till say 10:30, we should be okay. And again, if you can't stay up, you got other things going on, it's going to be the same thing looking at it on Dropbox. We get all the questions, everything the same. So somebody had a great idea. So these are our politicians. Let's make it 8:30. We'll split the difference. Is that good? Okay. So I don't know who everybody, whoever thought of those is good. Okay, so 8:30 it is. I'll set up the Zoom, okay, and I'll send that out. I sent out by email today the PowerPoints for tonight's lecture and the next one, and that's really it. Okay, so everybody have a great Shabbos, have a great rest of the week, and I'll see you guys. Matzah Shabbos.
Frank, you're doing chapter 14 or 26?
I am doing, what's 14? Hold on.
Today.
I just did 26. I'm going to do, give me 1 second.
That's the 25.
Hold on. I am going to do
Soft tissue trauma?
14. We did 14 today. We did 25. We're going to do 26. Matzah Shabbos. Okay?
All right.
Okay. So everybody have a good night. Okay. And where is the quiz? I'm still working on it. I don't know if you know, but COVID is very crazy right now. And I'm up to my eyeballs with meetings and everything like that. But I'm still trying to work on it. So, okay. So Matzah Shabbos, and everybody have a good rest of the week. Get some rest.
When are we going to have time to go over? Because usually we do it Matzah Shabbos.
I know, we will. We'll listen. Hopefully this week we'll catch up, and the next couple of Matzah Shabbos we'll do it. And then we have to decide Hanukkah if we want to have a late night. We're not having any classes on Hanukkah, but if there's one night that somebody wants to do something, 9:30 or 10, we can do something then too if after you're done.
Definitely a Hanukkah party.
Okay.
We can do some latkes.
If I have greasy food, then I can't teach.
Not asking to teach, you're just asking to eat.
Okay, but I'm saying I can't stay there that long either if I have greasy food. Okay, so everybody have a good night, and I'll talk to you guys later.
Good night.
Take care.
Good night. Good night.